the Kenyan Ministry of Agriculture will be with us this morning, as well as the Ministry of Health. So let's start. I will first start by giving you reading the agenda. So this first session, we start by the welcome remarks and the opening session. So our first speaker will be Yenwe from Africa CDC, then Mobile from ISLM, Patrick Mubangazi for the Fleming Fund, and then we'll have the Ministry of Agriculture from Kenya and the Ministry of Health from Kenya. So without further ado, let me call the first speaker, Mr. or Dr. Yenwe.
Thank you. Good morning. Wow, a fully packed room, huh? And I like the flags. You know, everybody has a flag. I don't have any flag, so I represent all of you. Let me start by recognizing our colleagues from Ministry of Health and Ministry of Agriculture, Kenya, the CEO of ASLM, and all partner representatives, funding agency. I don't try even to call name of partners because there are too many. So if I start calling, I will miss some of them. So I would like to acknowledge the presence of important partners, all of them who have been collaborating in this project. And I would like to recognize all of the participants here. So welcome to this very important meeting on antimicrobial resistance. I think this community really understands, the magnitude of AMR because you have been dealing on daily basis. So AMR, as it stands today, is a global emergency. I hear people saying it's a threat, but this is emergency already, so it's not really a threat. So, and 7 years after the adoption of the Global Action Plan on Antimicrobial Resistance by the United Nations General Assembly, we are still in the same situation. So there is any sign of improvement in terms of the magnitude of AMR and all parameters. The data that was collected and every parameter indicates that the situation is becoming even worse. And I try to really understand what is the problem. If you have a high-level commitment like by the UN General Assembly, African Union, WHO, and everyone, so why are not we progressing in terms of measurable terms on antimicrobial resistance? So the reasons are many, but I would like to point out very few things. One is, as you know, there is no a single solution for AMR. It requires a multi-sectoral approach, and bringing all those multi-sectors, the human, agriculture, environment, and many others, is difficult. I know you have been trying to play that bridging role as the AMR coordination committee in each of your member states, but it has been really very, very challenging. And then the second one is, so despite that high-level political commitment, there are no resources for AMR program. There is no funding. We have very good ideas there, we do have important strategies. However, to implement those strategies, there is no any funding. If we get a funding, a fraction of the funding that some diseases get, like HIV, TB, or malaria, I think we could have changed, the whole landscape of our work on AMR. So that is the second reason. So the third one is, research and development on generation of vaccines and new antibiotics has been outpaced by emergence of drug resistance. So we all of us know, the discovery of penicillin was a revolution in therapeutic medicine. So where is penicillin today? It's difficult to find benzathine penicillin to treat syphilis in a market today because penicillin became almost an obsolete drug. Ceftriaxone used to be an important drug for treatment of gonorrhea, and today resistance is very high. Azithromycin, which is really an important drug to treat multiple infections today, is going to be in that situation as well because it's being used left and right. So this means that there are no new antibiotics coming in, and the emergence of drug resistance is taking over. So we are in that situation. And the fourth one is that despite the attention at higher level, so the infrastructure remains poor for antimicrobial resistance detection. Few laboratories do antimicrobial sensitivity testing. In fact, as part of your data collection here in involved member states, only 1.3% of labs do microbiology testing. So which is really, a very huge challenge. So the last one is, of course, regulatory processes are not reinforcing the antimicrobial stewardship. There is no reinforcement mechanism. I can go to a counter in a pharmacy in any member state in Africa and buy any drug, any antibiotic, even if it has been reserved for second-line treatment, so I can buy it. So that is the situation. So because of this, we are not progressing anywhere on antimicrobial resistance. So this has to change. So if you see the situation in Africa, so it is worse because of prevailing situations, hospital care, infection prevention, all those are still not practiced very well. And if we see the magnitude of AMR in Africa based on the class reportable pathogens to WHO, that is a significant underestimation, because the report comes from one national reference lab, or it comes from one or two subnational labs. So this is huge underestimation. So at African Union, for us this is a priority, and the African Union heads of state and government, they adopted a common position on AMR in 2020. And we have Africa CDC worked with the AU task force on AMR control, and we launched the framework on antimicrobial resistance, which encourages countries to strengthen the surveillance program, and you also do some high-level motivation to delay emergence. If emergence of drug resistance is there, and we need to limit transmission through implementation of infection prevention control strategies, and also generally strengthening your standard of care in your hospital. And then, finally, if transmission occurs, then we need to limit the harm by introducing better treatment guidelines that will guide clinicians to really, do, evidence-based decision-making in terms of selecting the right antibiotic. So that is what our framework describes. And I think we have shown some progress in the last, couple of years, but we have a long way to go. And this project that we'll be discussing particularly today and the next 2 days, I think this has been a courageous decision by a funding agency to bring all of us together. As I said, in a program where there is no really resources. So this has been the first attempt to collect data from multiple countries, even though it's retrospective. So this has been a milestone achievement for the continent, and the findings you will listen to in one of the presentations as we move on. I think they are worrisome in many ways. So the resistance level is very high, as expected, and the most important finding is that the infrastructure is still poor. There is no microbiology laboratory service in most of these countries. It's only few. So it calls really, an urgent attention to strengthen our surveillance program and microbiology lab service. So as Africa CDC, we would like to really, collaborate with all of you, the partners here, to strengthen microbiology lab service and to generate more representative data, moving forward in a form of prospective study as a form of sentinel surveillance. Because, on a prospective study, a retrospective study, you don't control many of the things. Clinical information is incomplete, and quality of laboratory testing may not have been maintained. And that's why, out of those 12 priority pathogens by WHO, only 5 were consistently detected as part of this collaboration. So there is a gap. So we need to really, bridge that gap. So finally, let me reiterate that we are committed as African Union. So I would like to take this opportunity to thank Fleming Fund, the UK government initiative, to really support us in this endeavor. And our collaboration with ASLM, I think that's unique. It's a strategic collaboration. So we would like to thank ASLM leadership and the staff for working hard and to bring all of this together. And I would like to thank my Africa CDC team for moving this forward as well, and all of you, the partners and the participants. And moving forward, I expect in terms of phase 2, we have now, the information in terms of the gaps. So phase 2, maybe dedicated to strengthening the capacity, the deficiencies that were identified during data collection in phase 1, and also expand in terms of geography, include more countries, so that we can have a representative continental data on AMR that will be helpful to make some of our decisions. So I hope this will be a successful deliberation, and we would like to really commit as Africa CDC to implement any recommendations that are coming out of this meeting. Thank you.
Thank you to Dr. Yenwe for his insight on IMR as a public menace and his view on the way forward. Now I would like to call the CEO of ASLM, Mr. Ngobile. I hope my pronunciation is right. Mr. Ngobile, please.
Good morning, colleagues. Thank you so much for coming. So let me start by warmly welcoming you to Nairobi, to Kenya, and most importantly to this meeting today, the AMR consultative meeting. I just wanted to really appreciate the team, the ASLM team that has put this meeting together. I was just looking at some of the brochures that they've put in your, those plastic pockets. And what came across to me is that if you want to get a very simplified summary of what has been happening, I think this has been well articulated in some of these beautiful brochures. Please take time to look at them. They really summarize the message in terms of why we are here and why we need to continue to have this conversation. So let me also welcome all the partners that are here. I think the multitude of us here from different organizations, I think it's a clear demonstration that this is an important area, this is an important topic, that cannot be tackled by one institution, but we need to come together if we are to address this threat, this emergency, as Dr. Yenyu said. So let me also appreciate and recognize the presence of the Africa CDC, who have been very key in driving this, and thank you so much for your guidance and also for your leadership, Dr. Wande and Dr. Yenyu. I also want to recognize all the leadership from the governments that are here, also from different sectors. I know some of you were talking just a couple of hours ago virtually, and I'm so excited that we are actually meeting again in person. So thank you so much for coming. So to me, this is an important meeting because we need to continue to discuss how we can support and strengthen the capacity in Africa in terms of combating this silent pandemic of antimicrobial resistance. We are here because this has become a global emergency, no longer a threat. And I was looking at some recent statistics and they demonstrate that we have an emergency indeed. Some estimates that over 700,000 deaths are happening annually due to AMR, and Africa is actually bearing the largest share in terms of mortality and morbidity. There's a survey that was done and is published in Nature that shows that actually antimicrobial resistance is killing more people than HIV or malaria. So that's how serious this emergency is. And also those that do some projections, they estimate that by 2050, if we don't do anything about AMR, we are going to have up to 10 million deaths occurring annually. So the impact to us socially and economically cannot be underestimated. And this is therefore highlighting the urgent need to accelerate our actions to contain AMR across the continent and beyond. So coming to the role of the African Society for Laboratory Medicine, ASLM. So the ASLM has led and continues to lead the initiatives to improve laboratory systems and infrastructure in Africa to respond to both present and future challenges such as AMR. Strong, high-quality laboratory systems that produce data through antimicrobial susceptibility testing on microorganisms causing diseases across health and other sectors such as animal, food, and environment sectors are essential to these efforts under the One Health umbrella. This information is crucial for diagnosis and treatment, as well as for guiding our strategies for surveillance and response. So through the Fleming Fund, grants such as the MAP, the EQ Africa, and the Quarries, ASLM and partners are contributing to two important areas. Number one, in terms of strengthening the quality of testing and the AMR data generation and its use. And to date, ASLM and partners have established a regionally owned and operated EQA program for AMR covering 132 AMR national reference laboratories and sentinel sites across 14 countries. And we have also supported 10 laboratories to gain accreditation to international standards across One Health sectors. Secondly, we are also addressing the shortage of skilled professionals with the laboratory and epidemiology expertise that is needed for effective management and surveillance of antibiotic-resistant infections. We are doing this not only in Africa, but also in Asia. This skills development initiative intends to quickly bridge the gap in AMR surveillance and at the same time offer individual career benefits. So as far as a shortage of skilled professionals, what we have done as ASLM together with our partners, we have trained over 330 laboratory and epidemiology professionals working in AMR surveillance network in 17 countries. So we are here today to take stock in terms of our accomplishments, discuss any challenges, any obstacles, and also lessons learned. And finally, we need to decide how we move forward. As we draw from your collective wisdom, experience, and expertise, each person here today has a crucial part to play in this process. To continue addressing national, regional, and international priorities, we will need your input and direction as we define our strategies and plans for the next phase of the grants. I would like to take this opportunity to thank each of you for your contribution in the success of the programs up to date. We remain committed to working closely with you to ensure we continue to build on these successes to strengthen our systems to meet this global emergency. A special note really to appreciate and thank the Fleming Fund team that is here. Thank you so much, Luna, Patrick, and Joe for coming, and also for the generous support and funding to this very important initiative, and to all our consortium partners that are here today for all the technical expertise and support. Thank you so much, and I wish all of us a successful and fruitful meeting. Thank you.
So once again, thank you to the CEO of ASLM for his take on AMR as a public health emergency that need and require multi-partnership, and also trained workforces, adequate resources, and funding. Speaking of funding, let me call the representative of the Fleming Fund for his welcoming words. Mr. Patrick.
Thank you very much. Representatives of the Ministry of Health in Kenya and Ministry of Agriculture, I have to make a formal speech because sometimes we get misquoted. The representatives of the Africa CDC, ASLM, WHO, FAO, World Organization of Animal Health, delegations, country delegations, EXA, WAHO representatives, and delegates from all participating countries in your respective capacities. And then lastly, our good team at Mott MacDonald and Fleming Fund, ladies and gentlemen. I'm delighted to be here today to participate at this AMR consultative meeting, which will discuss different approaches of several regional grants in phase 2 of the Fleming Fund. And all this will continue to contribute towards tackling the growing threat of AMR. Ladies and gentlemen, the £265 million global Fleming Fund investment from the UK DHSC has deepened countries' collaboration and reflected on a shared understanding of the importance of tackling drug resistance. We must not forget that the COVID-19 pandemic has demonstrated the need to boost our diagnostic capacity, health security, and it has also shown the crucial interdependence between countries. The UK Special Envoy on AMR, Professor Dem Sally, has often said AMR cannot be tackled by one country alone. And this was the genesis of the Fleming Fund, which seeks to collaborate with all the countries. And our mission as the Fleming Fund is to support generation of data and making sure that this data enters into the hands of decision makers. To achieve this, we have continued to work with government stakeholders, AMR at national level, regional level, to support development of AMR surveillance systems, which will enable countries to develop and have targeted interventions to reduce the serious human costs and economic cost of this resistance. In the last 4 years, actually the last 6 years of the Fleming Fund, we have worked with country partners, grantees at regional level and at national level to strengthen the governance structures. We have participated in contributing to the renovation of reference laboratories and other laboratories, and we have contributed to the procurement of reagents and consumables and high-level, high-tech diagnostic equipment at national level. And we have also funded and supported the growing number of the Fleming Fund Fellowship scheme. So Fleming Fund is proud to continue supporting these regional initiatives and national projects. And the Fleming Fund and Mott MacDonald in particular look forward to continued collaboration in the second phase of the Fleming Fund, which will emphasize data generation, data use, and most importantly, ensuring that Fleming Fund investments that have been made at country level are sustained. We shall do this by working with governments, partners, UN agencies, Africa CDC, ASLM, and other partners that support countries to ensure that we find an approach to support sustainable investments into laboratories. And it is our hope that this international collaborative approach will continue in phase 2, and with our refined one country approach. I must emphasize that. One country approach will bring together all the Fleming Fund investments at country level to ensure good coordination and synergies, and so that we can explore together the opportunities for mutual benefits of our countrymen and countrywomen within Africa. I thank you.
So, on that note, let me call His Excellency the Ministry of Agriculture of Kenya.
I think the battery is giving up. But, well, the representatives from Africa CDC, the CEO ASLM, colleagues from Mott MacDonald and Fleming Fund, distinguished delegates, good morning. Good morning once again. Well, I would want to first and foremost welcome you to Kenya and to this very important consultative meeting. We all know the impact of AMR on both human and animal health on the continent is significant. And it's of great concern. And as the policymakers and healthcare providers, we must take steps to ensure that we are equipped to combat this silent pandemic. It's literally dying. Well, I'm a very soft-spoken person, so my voice cannot be projected so high. Thank you. Let me resume my official remarks by saying that the Kenyan government has made significant strides towards addressing AMR since the development of the AMR National Action Plan in 2017, which is currently being revised to undertake a new, the second phase, which runs from 2023 to 2027. The National Action Plan outlines the country's strategy for prevention and controlling AMR, including improving infection prevention and control measures, promoting rational use of antibiotics, and strengthening surveillance and laboratory capacity. Although much is still needed to be done to implement strategies in AMR, national action plans in Kenya, other countries, we are delighted that the continent, with the support of Africa CDC and ASLM, through the Fleming Fund regional grants, is at the forefront of addressing this critical issue. In Kenya, we fully support these efforts and are actively engaging in raising awareness and contributing to the discourse on the significance of diagnostics, quality, data generation, and ensuring the availability of skilled personnel to combat the growing AMR challenge. We are honored as a country to host this crucial dissemination meeting, having also benefited from all three Fleming Fund regional grants. I would also want to add that we've also benefited greatly from the global grant through WOA, FAO, and WHO, and we have also further benefited greatly from the country grant, which we are finalizing within the next month. The Fleming Fund Mapping Antimicrobial Resistance and Antimicrobial Use Partnership has provided a baseline analysis of AMR testing capacity, trends, and risk factors in Kenya and other countries. This will be valuable for developing country-specific solutions to the gaps identified. The Fleming Fund External Quality Assurance Grant for Africa, EQ Africa, has increased the existing regional AMR EQA provider capacity at AMREF Health Africa in Kenya. This has seen the human health and animal health sectors laboratories accessing EQA panels as part of their quality management system requirements. The Fleming Fund qualifying the workforce for AMR surveillance in Africa and Asia has seen 30 microbiology and epidemiology professionals build their AMR surveillance capacity through this important training program. Additionally, our directorate, that is the Directorate of Veterinary Services, where I'm domiciled, are proud beneficiaries of this support after successful mentorship and accreditation under the ISO 17025-2017 for the microbiology laboratory of the National Veterinary Reference Laboratory in Kabete, in addition to EQA support for our 6 regional veterinary investigation laboratories. As countries, we need strategic partnerships, collaborations, and a multi-sectoral One Health approach to mitigate the AMR on the continent. I hope that the discussions in this meeting will result in actionable recommendations to effectively address AMR, and look forward to productive deliberations over the next few days. We would like to express our appreciation to the government of the United Kingdom for their generous funding through the Fleming Fund, which has made these efforts possible. Thank you, and I wish you a successful and fruitful meeting.
Thank you, Mr. Minister of Agriculture. Without further ado, I will call upon His Excellency the Minister of Health from the Republic of Kenya for his welcoming remarks.
Thank you very much. Good morning, everyone. Good morning once again. Karibuni sana, we say in Kenya, karibu. Feel at home. Kenya is very a welcoming country, very friendly people, so feel at home. Representatives of the African CDC, Dr. Yinu Kabede, Dr. Yewade Alimi, Dr. Shenafi, representatives of the ASLM, Mr. Ndlovu Gombile, Dr. Pascal Ondoa, Dr. Manta Talamo, Ms. Megan Kelly, representatives of the Mott McDonald, Mr. Patrick Bagizi, Ms. Lona Pari, representatives from REACT Africa, representatives of WOA, FAO, different partners and collaborators, representatives from the different countries who are represented today. It's my honor and pleasure today to join you in this auspicious meeting where we want to discuss and share lessons that we learned during the implementation of our Fleming Fund regional grant. You all agree with me that tackling AMR requires collaboration from all the different sectors, from all the different countries, and more important, especially in our regions where our challenges are common, challenges around resources, challenges around access to services. So we need to share experiences and lessons, and this meeting presents the most opportune moment for us so that even as we proceed to the next level of implementation of the Fleming Fund, we can be able to learn from these lessons that we have presented before. So as a country, we have benefited from the Fleming Fund in different ways. For example, in terms of surveillance, AMR surveillance and AMR consumption and use monitoring, these are very critical because we are all aware that without data, we would not be able to make informed decisions. Case in point, in the review of our guidelines, which have reflected the trends of resistance We have been able to review our Kenya Essential Medicines list. We've been commenced the review of our treatment guidelines, review of our National Action Plan, which is on course at the moment, and these clearly point out the importance of taking data for decision making. In terms of skills development, the regional grant has supported the development of skills and knowledge, especially for epidemiologists and microbiologists, and this has been very critical. We have seen the improvement in data generation and use in the different areas. We have been able to generate baseline data on antimicrobial use and consumption thanks to the mapping of antimicrobial resistance and use partnership program. And we are hoping that even as we go ahead, we are going to leverage the skills and the knowledge and the data that we have been able to generate thus far. So we thank you very much, the different partners, some who are not represented here, for the collaboration and support that you have always been extending to the different structures of governance. And I'm sure there are a lot of lessons that each of the countries has been able to learn, which we are going to share during the days that come ahead, so that we can improve on the control and mitigation of AMR. So we are delighted to join this meeting. We are hoping that the deliberations are going to be fruitful, and we are all going to learn from the discussions that are ahead. So mine is to welcome all of you. Feel free, network, take the opportunity to share with our colleagues. So thank you very much, and karibuni.
Thank you to the Minister of Health. I think I exhausted all my English, so I will switch to what I know best. I'm going to speak in French now. So, alors, merci au ministre de la Santé de la République du Kenya pour son mot de bienvenue. Nous allons maintenant passer à la présentation du docteur Pascal Ondoa, qui va nous entretenir sur les attentes de cet atelier. Dr. Pascal.
Merci, Joël. Good morning, everyone. Okay. So, dear representative from the government of Kenya, representative from Africa CDC, ASLM CEO, representative from the Fleming Fund, dear representative from the country, dear friends, actually, because it is, I remember that this is our fifth continental meeting on the Fleming Fund project. I am truly honored to have done that journey with you since 2019, before the COVID. I think we were in Addis Abeba. Then we met again in Addis Abeba to close, the first phase of the MAP meeting. And we've been twice talking about EQA Africa. Today will be the first time that we actually talk about all those three grants. So my name is Pascal Ondoa. I'm the Director of Science and New Initiative at ASLM. And it has been a pleasure, a challenge, a honor and excitement to lead this portfolio of AMR on behalf of ASLM in the last 4 years. So hopefully the slides are going to be on the screen so that I can start. So it is really also very humbling to see 14 countries here today, which represent like a big chunk of Africa, not all of Africa. I think that our colleagues from the Lusophone countries, from North Africa, from the islands are not here. We hope that we will be able to actually welcome them in the next phase. Can somebody confirm that the slides will be shared? All right. Okay. Thank you. So my task is to talk about the meeting's objectives. So I see the slides are a bit distorted, so apologies for that. So what are we going to talk about today? So first of all, I wanted to... All right. So first of all, I wanted to reflect on the title and the general theme of this meeting. We are going to go from awareness to action, and we are going to unlock the power of the data and One Health. So that means that compared to 2019, when we started most of those projects, we now have a lot of evidence to allow us to take more action in order to tackle AMR. So on our task list, you will see from the concept note of this meeting, we will review the current AMR priorities on the continent, including the Africa CDC framework for AMR control. So you have seen that we have worked hand in hand with Africa CDC and other partners, and our goal is really to support that this framework is being implemented on the continent. We'll review the outcome of the phase 1 of those 3 Fleming Fund regional grants and the implication on the national planning, the NAPS and other plans, the implementation and investment strategies for AMR containment. And particularly, I think we'll really highlight the fact that combating AMR is not only a matter of national AMR plan. It also involves all the planning, like the National Laboratory Strategic Plan, or the plans for human resources development. And we'll collect the country recommendation on what should the phase 2 strategy and activities look like. So who participates in this meeting? So you can see on the left the countries that are led by the AMRCC. So when we say countries, we really mean the officials that are mandated to implement their AMR containment strategy. So you see all the countries here. 14 countries. We have the regional and global stakeholders, the government of Kenya, the high officials of Africa CDC, ASLM, EXA, WAHO, and the Fleming Fund. So that really means that we have the endorsement and the support of many stakeholders. We have on the right partners and collaborators. Indeed, like Dr. Kebede was saying, we cannot list them all, but you will see on the banners how many of them are here. And that really is a testimony of how inclusive this strategy of the regional grant of ASLM is, and how excited the partners are to collaborate with us to move the agenda on the continent. And we'll have some Fleming Fund collaborators. So we'll have the Kenya Fleming Fund country grantee is here. We'll have the course master trainers and graduates that are there. And we have some Fleming Fund fellows from Tanzania as part of their training. They can also be here to contribute to this discussion at continental level. So what will we bring back home? So we will have a documented country and stakeholders lessons learned and best practices from the phase 1 of the Fleming Fund. So you will hear different presentations of those different projects to explain what we have done, what were the potential bottleneck, and what is it that make this story a success. We'll have a consolidated outline of phase 2 strategies and activities aligned with national priorities of Africa CDC framework for AMR control, and that's really to further improve the AMR containment strategy. Now knowing what we know, what can we do better? So what will we do? We will share knowledge and experience from an African perspective, because yes, Africa is creative, Africa is agile, Africa is resilient, and we are going to share that expertise between ourselves and with the rest of the world. We will debate and we will reach consensus. So as I'm saying, this is the 5th time that we are consulting you. That really is to confirm that we are seeking for your input. We are not shying away for your input, and sometimes the discussions are robust. We welcome them because we consider that that makes our strategy even better. And we will have some recognitions during this meeting, because it's not only about working, but at some point we stop and we really see what we have achieved collectively and individually, because that is indeed something very important to make us do the work that we are doing. So I wish you very successful debates, And I'm going to end here and give it back to you, Joanne.
Merci. Merci au docteur Pascal pour cette présentation. Alors, nous allons modifier légèrement l'agenda. Donc, nous allons prendre un break de 20 minutes pour la photo de groupe pour permettre aux officiels d'y participer. Et après, nous reviendrons autour de 10h40 pour continuer cette session. Donc, so we are going to have a break for the group photo to give the opportunity to the minister to be on that photo with us, and then we'll come back at 10:40. We will resume at 10:40. Thank you.
Ministers that they have a strategic political commitment coming from the African Union that can guide the work they do on those other sectors. In 2020, for the first time on the continent, commitment, it only took us, it's only when we got to 2020 that our heads of state really prioritized this. And I think you should be proud of yourself because we getting that endorsement was as a result of sort of the momentum, the advocacy that many of you as AMRCCs did across your previous countries. So just, this is just a visual representation of sort of that narrative that I gave to you, the launch of that framework. Many of you are in the room right now or joining us online are represented in this picture. So what does the African Union really sort of talk about when we talk about AMR? Like I said, you know us as Africa CDC. You know us in terms of the work we have done on AMR, on COVID-19. But beyond the Africa CDC, important on AMR aims to be the primary coordinator of AMR control on the continent. We aim to contribute and create an enabling environment to ensure that the work of you member states is really implemented and advanced. The work of our collaborators across the UN agencies, development partners, funding partners, and of course Pan-African partners that are doing remarkable work is we have the right enabling environment to do this. Beyond that, as the African Union Task Force on AMR, it's our role to take your priorities to your heads of state and president to ensure that we can increase the political commitment, mobilize resources, and promote policies to improve AMR control. One of the nice examples that I always like to think about is, one of the challenges that many of you will talk about is falsified and substandard medicines, antimicrobials. Very recently, the heads of state endorsed the African Medicines Agency. Now this is another technical agency of the African Union that will really ensure that you have enforcement mechanisms in place when you think about drug importation, drug consumptions, and drug sales in the countries. So this is just what it looks like, and we have our leadership up to an endorsement up to the office of the African Union chairperson. So why is this work important as the African Union Task Force on AMR? Our sort of unique value to the work we do is really on that political status of the African Union. Audience, we have the ability to convey and to present your sort of priorities on AMR to the level of the heads of state. Beyond engaging the ministries of health, we have that convening power to be able to engage ministers of agriculture as well as environmental health. The African Union, and of course by proxy, the African Union Task Force on AMR, has that authority to mandate financial contributions from member states. Perhaps it's a time for us to think about having such resources for AMR at the continental level. We have done similar with the COVID-19 fund and other sort of outbreaks that have gone on. Beyond that, we have that authority to strongly influence member states to across across all sectors that impact health. Lastly, I think it's our access as the African Union. As you know, you're seated here as representatives of your member states, but you are really the African Union because there's no African Union without member states. As such, we have that access to ensure that we can leverage existing infrastructure mechanisms to be able to support you where other partners are not able to. So just really bringing it very closely so you understand sort of the work that we have done as the African Union Task Force on AMR. For the first time on the continent, the heads of states, like I mentioned, made a political declaration, and that is the AU Assembly Declaration 33, the African Common Position on AMR. So primarily, for the first time, the continent recognizes that despite being a global threat, Africa remains one of the most vulnerable populations across the globe. Think about access to medicines, vaccines, infrastructure, like Dr. Yeniu mentioned, and many of you know in terms of the capacity of the laboratories we have on the continent. We strongly recommend a One Health approach, ensuring that no sector is left behind, and that is the best approach for us to be able to use as the African continent. Beyond that, we are very keen to support our member states to prioritize and invest in implementation of the national action plans, which I will talk about in my slides. Our colleagues, I'm glad that we have Dr. Evelyn and Dr. Sal online. It's really to work with our regional economic communities to ensure that we have harmonization of antimicrobial agents used in humans, animals, and plants, as well as developing sort of continental or regional protocols in place. Lastly, we are very proud of this work because for the first time, the African Union Commission committed to fully constituting the work that we do to ensure that we're able to monitor, review, and coordinate all policies related to AMR to ensure that we can fully support the work we do. So going very quickly to our framework, it's really, I think it's available online, the African Union Framework on AMR. As you can see, we are not waiting for we're not waiting for anything special, groundbreaking data. We are acting now, knowing that we know enough to make those changes as required. We are working with a One Health approach, and I wish my colleagues from AUIBA could be here today, but unfortunately they have other commitments, and so that's why I'm presenting on their behalf. But most importantly, our work as the AU, we're able to really channel that power to have high-level political commitment as well as advocacy. We are very keen to strengthen the work you do, particularly on your human resources, on AMR surveillance and control, but mostly to help understand awareness and understanding of AMR. So very quickly, I will try to talk about the primary goals of the African Union Framework for colleagues who may not be familiar, but many colleagues who have been working with us already know that the work you do in MAP, EQA, Africa, and WAS is all to sort of achieve the goals of this framework. So very quickly, we have a few priorities when it comes to improving AMR and AMU surveillance across the continent. It is not just in the human health sector, but we're trying to scale across agriculture sector as well as the environmental health sector. The work that the AUIBA colleagues are doing is really to work through the veterinary public health institutes and the national veterinary labs to map out the capacities and the capabilities of these veterinary labs to be able to do bacteriology. They're also working to improve the quality assurance programs in these labs, and of course we will be giving you updates as soon as we expand that portfolio. One of the things that is quite critical to this meeting is really having countries, it's not so much about collecting data, but what do you use the data for? I mean, many of your countries have been contributing to GLAS, but when it comes to feedback mechanism, improvement, addressing some of the gaps that you have rightly raised, what are the mechanisms in place? So primarily, we want to support our member states to continuously collect, analyze, report, and disseminate AMR data. For us, the vision is, at least in the next coming years, Africa has a good visual representation of what the AMR trends and body is across our 55 member states. Now looking at issues around delaying emergence of AMR. One critical gap that we have reviewed is really beyond having an enabling environment. Countries just don't have some policies in place. When you think about national treatment guidelines, national essential medicines list, or even facility level treatment guidelines. So primarily we are trying to work with physicians and other human health providers. The colleagues in AU-IBA have already started to do a lot of work around supporting veterinarians, para-veterinarians, and of course, food producing manufacturers. One of the things that is critical is we did a mapping to try to understand where the barriers are, particularly in food producing countries and the use of antimicrobials in those countries. So this has been presented to the Ministers of Agriculture to guide them in terms of enabling laws as well as policies that can really. Lastly is something that is critical but not talked about because it's a very low middle income settings kind of problem. Issues about sales of substandards and falsified medicines. And this is where the African Medicines Agency comes into play. And now the third objective is on limiting transmission, and this is where our work on infection prevention and control in healthcare facility comes into play. We have developed and endorsed a legal framework, and we are currently supporting our countries to have a legal framework on IBC. We are also working to strengthen biosafety, good animal husbandry, and good animal practices and vaccinations in farms to ensure that we are able to reduce antimicrobial use. We're also working on strengthening WASH activities in the community as well as in hospitals. Lastly, I think a critical thing that we need to address is availability of diagnostics. For us to be able to have good AMR surveillance data, for us to be able to have well-informed treatment guidelines, it's important that diagnostics are readily available to our countries. And so this is something that we are trying to prioritize, both availability, thinking about access, but also addressing issues of substandard and falsified diagnostics across the continent. Lastly is to promote access to essential medicines across the countries. So this is just a visual overview, just to highlight the work that the African Union Task Force already does with WHO, FAO, WUA, and UNEP across the continent. Through the coordination of the African Union Task Force on AMR, we have something called the Africa Coordinating Group on Antimicrobial Resistance. And to our team from Senegal, thank you very much. Last year we were hosted by the Ministries of Health, Agriculture, Wildlife, Fisheries, and Environment during the World Antimicrobial Awareness Week. Which brings us to one very important part that many countries always ask us about, the National Action Plans. One, we applaud you for all of the efforts done as far back as 2015 and 2016 to inform policies and strategies the African Union can support. This shows something very concerning for us. We try to understand the progress of implementation across the countries. And as you can see that many of our countries don't have, there's a positive improvement for One Health, but there still remains that gap. As you can see, only 8% of the countries already have an integrated approach, using an integrated One Health approach, or One Health coordination for AMR. We also look at the progress being made for revisions, thinking about your M&E framework, your costing framework. Many of our countries still have this gap, and we are hoping that through the work of the African Union Task Force on AMR, we are able to really support your efforts. We really hope that using the MAP data and the very concerning data, the 1.3%, you can really take into account the gaps in laboratory capacity and how it fits into your AMR strategies. Lastly, we hope that, and we intend to support your review of your national action plans to ensure that animal health and food safety issues are addressed. Finally, I think for the AU Task Force on AMR, research is very critical. Africa has been lacking in terms of AMR research, thinking about innovation, development, thinking about even new therapeutics to be developed. For us, yes indeed, we have that political strength. We're able to drive policy. But we need to be able to use continent context-specific data to drive this policy for your benefit. We believe that the research on AMR should be led by our countries, African Research Institutes, leveraging global partnerships. Our approach is working with you to identify, understand the problems, develop interventions that are sustainable, not just through external funders, but through domestic financing. Finally, your research priorities can be presented at the highest level of governance, that is the African Union. And we are hoping that the heads of state will be able to prioritize the research agenda and priorities of the African Union. Thank you very much.
Alors, nous tenons à remercier le Dr Yewande pour sa présentation sur le travail essentiel de la task force de l'Union africaine sur la résistance aux antimicrobiens. Et nous encourageons cette task force à continuer sur ce chemin, car il reste beaucoup à faire sur le terrain. Après le Dr Yewande, désolé, je crois que j'ai oublié mon programme. Alors, après la présentation, l'excellente présentation du Dr Yewande sur l'agenda de l'Union africaine. Donc je disais, après l'excellente présentation du Dr Yewande sur l'agenda de l'Union africaine sur comment tacler la résistance aux antimicrobiennes, nous allons avoir la présentation de Dr Luma Perry du Fleming Fund sur leur programme de financement en Afrique. Okay, let me maybe try in English. So, I was saying that after the one presentation on the agenda of the African Union regarding IMR, we will now go to the presentation of Luma Perry on the Fleming Fund program in Africa.
Thank you. If someone can assist me with the slides, please. Good morning, everyone. As Dr. Pascal said, it's a real pleasure to be here today. It's a great and wonderful event. So I'm Luna Perry, and I am the Regional Grants Coordinator at Royal McDonald's, the management agent of the Fleming Fund. And I'm going to talk to you, I'm going to give you an overview of the Fleming Fund, what we do, where we do it, what have we done in phase 1, and what we want to do in phase 2. So the Fleming Fund, as you might know, is a project funded by the UK Department of Health and Social Care. And the aim of the Fleming Fund is to respond to the threat, now emergency, of antimicrobial resistance. We support 21 countries in Africa and Asia. We have 11 Fleming Fund priority countries in Africa. And how do we do this? We invest in strengthening surveillance systems through a portfolio of country, regional grants, global projects, and fellowship schemes. Please know that this component of the Fleming Fund that is managed by Royal McDonald is part of a wider Fleming Fund that also provides support to multilateral organizations such as FAO, UNOHA, and WHO. So we, at Mount Macdonald, we have this portfolio of country grants, regional grants, strategic alignment grants, and the fellowship scheme. The Fleming Fund focuses, as you know, in low and middle income countries because, as you also know, are the countries that bear with the burden and the consequences of the problem of AMR. So what did we do in phase one? Mainly through the country grants, we have supported 269 surveillance sites in 21 countries in Africa and Asia. Of these, 176 are in the human health sector, and the remaining 93 are in animal health, veterinary services, food safety and environmental laboratories. We have a cohort of 181 Fleming Fellows. They have received medium-term professional development, and we also provide training, and we have recorded the impressive number of more than 20,000 training attendances. These, as I said, is mainly through the country grants, and we have the fellowships, and we also have the regional grants where MAP, EQ Africa, and QUAS are sitting. And the regional grants mainly support the country grant in technical issues around AMR, and they have been working on sorry.
Okay, I'm not sure if I can be loud enough, but the regional grants have been collecting data, working on quality assurance, establishing genomic surveillance networks, and also working on policy and advocacy for data, AMR data sharing. I was going to highlight the achievements of MAP, EQ Africa, and QUAS, but it's been highlighted already, and I'm sure this is going also to be seen in detail, so I'm going to skip that for now. So the achievements of the Fleming Fund in phase one, we have provided investment in 5 areas, and these are laboratory infrastructure enhancement, human resource strengthening and workforce reforms, AMR and AMU surveillance system strengthening, building foundations for AMR surveillance data use, and promoting rational use of antimicrobial medicines. So, because of these investments, the quality and quantity of AMR data, we've seen that it has been improved heavily, and it has been produced and analyzed from across the One Health disciplines in the human health, animal health, and environment. And there have also been some remarkable contributions to policy and practice, and also the raising awareness of the AMR problem. So that's what we have done in phase one, and what we want to do in phase two. Phase 2 has started already early this year in 2023, and we will provide a further 3 years of support. The Fleming Fund, as a grants portfolio, will end in March 2026, but we expect the grants to end by December 2025. We will work in the same 5 areas that I just mentioned. And in phase 2, we will focus on 4 outcomes that are based on our revised theory of change. And these are production of quality, AMR, AMU, AMC, and burden data, the quality analysis of the data, sharing these analyses and sharing this data with decision makers for policy changes, and promoting sustainable investment to counter AMR. We will have the same funding streams, the country grants, the fellowships, the regional grants, and the strategic alignment grants. And this grant will work together. And I'm going to read it from my notes because this is the most important thing I want to highlight today. As my colleague Patrick said, we will have a one-country approach. So these country grants, fellowships, regional grants, and strategic alignment grants, this grant will have to work in harmony to improve the production, analysis, data, and advocate for issues in policy and practice. Furthermore, we want them to combine forces to work towards the sustainability of the inputs of the investment of the Fleming Fund and make it sustainable in each of the countries. And finally, we have the inclusion of the strategic shifts. So this is a new thing we have in phase 2, and I'm going to talk to you about that, and with that I will finish. So the strategic shifts, the Fleming Fund will work on specific topics which promote effectiveness of data production, analysis, and use. So we want to see these strategic shifts across all the work, all the grants. Not every single grant will have all the strategic shifts, but when possible, we want them to focus in these areas. There will be some grants that will be particular for the shifts, but there will be other grants that they will have to incorporate some activities that relate to them. So these are animal health, One Health, and environment surveillance, data use for practice and for clinical engagement, and also data use for policy. The economic case for investment on AMR, birth and disease measurement, which relates mainly with the principles of gender and equity and sustainability. So that's what we want to do, and as you know, MAP, QUAS, and EQ Africa will be part of this phase 2, and they will have to build upon the successes and results from this phase 1, and now phase 1 can be seen as the establishment, and now they will have to move forward and work on the impact of the work they are doing. Thank you.
So thank you to Dr. Luna Berry on her presentation on the Fleming Fund and what to expect with the funding. So now we would like to, this is going to be Tracy Muraya from REACT. She will give a presentation on revisiting NAP.
Good morning, everyone. Nairobi, Kenya. My name is Tracy Muraya, as you've been told, and I work as a senior policy officer with REACT Africa. It's a pleasure to meet many colleagues. I think I last saw last year. So my task really is to take you on our journey as REACT Africa, our experiences as we support countries to develop and implement their national action plans on AMR. Luckily, the previous speakers have really spoken a lot about data, so I don't have to go through the data, and really just to showcase the lessons we've learned, the challenges we face, the enablers that we find on the ground, and really then how can Fleming Fund and the different programs within the Fleming Fund really utilize our experiences to then go on with the second phase. So that will be the outline. As you've already, I think, through Dr. Wande's presentation, you saw the number of NAPs in place, and this is also reflected in the quadruped tracking surveillance system, and that is 2022 data that we had 38 NAPs in place in Africa. Of course, most of them are expiring this year, if not next year. Some have already expired. We've had a representative from Ministry of Health, our national focal point in Kenya, already telling us that they are revising our current NAP. Now, Kenya is one of the 26 in the process of revising or developing the NAP 2.0s. Where are the other countries? What are the challenges that they're facing? Why haven't they started, yet some are already expired? Maybe if we can look back at the existing NAPs. Most of our NAPs are ambitious. In fact, I dare say over-ambitious. Yeah, thank you for laughing, because I know we all realize that. Yeah, but of course, this is no one's blame. This was an infant that we inherited, and we had to take on the blueprint of the Global Action Plan and really use it to guide us to develop these plans. And yes, we have started. And a lot of work, as you'll see, has been done, even with the limited resources and capacity that we may be perceived to have, and at times not necessarily even be limited. It's probably limited in our mindset. Most of them did not follow the due process. We did not go on ground to check on the data that we have, or the situational analysis for that matter. Of course, multisectoral engagement was non-existent actually. Most of them were human health driven and continue to be, but we thank the global policy environment, and then coming down now to the regional, the Africa CDC, WHO, Afro, and the rest of the quadripartite in really pushing the One Health engagement. So, for example, when we as REACT, together with support from WHO Afro then in 2017, went down to Zimbabwe to try and see how we can help in developing the National Action Plan. Back then in 2017, the implementation of 5 years was quoted as $44.6 million US. Now, the funny thing is, as much as we were saying about $7 million US dollars, not Zimbabwe dollars, per year, this particular initiative of developing the plan was actually funded by an external funder. So how then do we expect our countries to be able to actually come up with that money? Yet we didn't even have the political track at that point. As we speak, 54% of countries have limited capacity for multisectoral coordination. But that is improving, and thanks to partners like Fleming Fund, through the different initiatives, the regional bodies that are really holding our hands. And therefore, moving from paper to action has definitely been the greatest challenge in our region. REACT Africa has been able to support the countries that you see in red directly in terms of technical support in developing and implementing national action plans. This takes form in different ways. It could be the actual development of the tools themselves, or even just through innovative activities, as you will see. So how does our support really look like? So in addition to what I've just mentioned, we focus on stewardship of not only, well, we are quite centric towards medicine use, and I also want to say human health. However, as we all know, we have to progress towards One Health approach. So I thank Dr. Chizimu, who's here from Zambia. He can attest that we are currently in Zambia, supporting with the NAP revision process. Zambia were very, very ambitious in making a 10-year plan. Yes, but it's working. So now what we're doing is just helping them revise. Now they're in need term. So we're helping them revise as if they're going to 2.0, right? Taking into context that now we need to cost these documents. We need to work with what is on ground. We need to engage environment, animal health, food and agriculture, you name it, including students. So that's what we are doing with our countries. We are on ground also developing and implementing national policies and guidelines on stewardship. For example, in Kenya we are actively involved in a county called Makueni County, which was actually a pillar in work directly to influence AMR or indirectly. We incorporate the media team, or rather the media fraternity, build sensitization amongst them. And our most recent achievements, if I may call it that, or new babies, we have our students and religious leaders. I'll come to the students a bit later. And then we have our famous REACT annual conferences, during which a lot of cross-learning and fertilization occurs, especially amongst our AMR CCs representatives. We have the regional Africa CDC, WHO Afro, let me call it the quadripartite, that come on board, different funders, NGOs, and I'm glad actually because the people represented here, quite a number of them, do attend. So, we are happy with the little that we have. We are happy that Fleming Fund has renewed and is coming on board to really support our people. Why? Because during the 1.5 years that Fleming Fund was re-strategizing, if I may put it that way, we've seen real issues on ground. So I will not mention which country, but you go down and you had left, you know, the lab and the stewardship of antibiotics really going well, and the IPC really going well because COVID really, you know, woke us up. However, reagents are no longer coming through. Fleming Fund have done an outstanding job in equipping our labs. However, Fleming Fund will not always be there, let me put it that way. Now I stand as a CSO. They'll not always be there. So then it's up to us, as I believe Dr. Ewanda said, to then take it back to our political key stakeholders, that even with the data that we get, with the data we produce when you're seated there, then the work that partners like Fleming Fund are bringing on board needs to continue, right? So we have an antibiotic treatment guideline now that is currently in Zambia in one of the institutions. That's how some of our people collecting data, and we don't just go there and collect data, we incorporate the healthcare workers there. We update our coordinating teams at the AMR CCs, or rather CCs. We build capacity, and after building capacity, we actually accredit, or rather acknowledge that you know, these folks have been trained, and so that they can go forward and champion. I said that I will belabor on our student work. Now, we sat down and really thought, we keep saying the youth are the future leaders, but most of them had no idea what AMR was. So back in 2019, starting 2020, we started what we call an AMR leadership program for tertiary students. We started as a physical session. Unfortunately, COVID happened, so we had to move on to virtual sessions, and that's what you see on your right-hand side. It took 6 months, and we had experts, some of them presented here, or rather sitting here, and probably also in the virtual forum. And we were surprised that we only targeted about 100 students, but we had an overwhelming response of over 30. Uganda had the highest number of participants. However, we had Nigeria as the highest number of applicants. Unfortunately, because of the limited resources, we could only take so many, but we will come. We are seeing such an innovation coming from these young folks. And at the end of the virtual sessions, we are able to actually meet in a congregation like this and award their efforts. They're able to present, make their presentations of their innovations, and from there we're also able to plug them in with mentors that are able to help them further fine-tune their work and be able to hopefully come up with something that we can use. We have to accept that perhaps we who are seated here, our minds are maybe now in the regressive phase, while the students are now progressing. So that's Kenyan chapter that started first, and then we had Uganda about 3 weeks ago. We also engaged primary school children. Last we engaged them, which was the other year, they were able to engage in an art competition and be able to express what they understand. AMR versus environment, AMR versus the food they consume, AMR versus malaria, whatever the children understand. And we're hoping that at the end of this year, actually, we'll be able to come up with a little booklet that shows what our children understand in this particular part of Africa. We've been able to collaborate with some partners and help the children to use locally available material to make the little leaky taps or tippy taps, as some may call them. That's the media that we've engaged. And now we have our new baby, religious leaders. Now, when you build capacity of these religious leaders in Africa, we all somehow subscribe, at least over 90% subscribe to some form of faith. And they're able to come up with our guidance, the different IEC materials they use during the different, not necessarily, let me call it preaching sessions, but during the different health forums that they have in their churches. Our annual conference last year was graced by over 120 participants physically. Virtually we had even more. And we are happy to say that we had representation of at least 23 African countries. And this means that our influence is not just in the ones that we go directly on ground, but even those that come and exchange their innovations, their experiences, their lessons learned through our One Health approach. So our challenges, as has been said, we have so many conflicting priorities as countries. I know this has been seen before by anyone who's attended our conferences, but this is just an example of the TB program in Kenya back in, that was the strategic plan 2019 to this year. So the full cost was supposed to be 29,800,000 Kenyan shillings. However, we had only about 14 coming in, and majority of it was from external funding. And that's the AMR situation we find ourselves in. So, in addition to that, we have weak coordination among our multisectoral teams. The Ministry of Finance is really not engaged at all, I dare say. And if they are, in very few countries. So we need to bring these guys on board. Fleming Fund, we're asking, when you do that economic analysis, break it down to not only pounds and dollars, to kwacha, to Kenya shillings, right? Let our people understand. If Fleming Fund don't do it, then you are the people on ground. Please break it down and let them understand what it means to have one patient in the hospital for over a month, for example, or to have animals dying and threatening our food security. Technical expertise, of course, has been said already. We have weak health systems and weak regulation, but we thank God that AMA is on ground, and we also advocate that you also lobby for our policymakers to actually ratify these documents that come through African Union. Limited awareness and comprehension of AMR because of its faceless nature, and hence then the lack of political will. That's not new, right? That next photo is out of stock situation. But I wanted to show you also the infrastructure that we deal with in the health sector. So our people have to sleep there during night duty next to empty shelves, unfortunately. We are talking of diagnostics. Our people only have that. True or false? Yet we are saying AST, come on. Right? We need to really think outside the box. For example, MSF has now launched Antibiogo, I believe, if you read about it, which is a mobile AST platform, and hopefully, let's see what it will do. And I just wanted you to see that. Those are the prescriptions we deal with. Yet we are saying misuse
So whose prescription is this? Is it Tracy's? I don't know. Yeah. So how do you get sensitivity data from that? What was the diagnosis? I have no clue. Anyway, lessons learned, proposed solutions. I'll just quickly speak through that. That ideally evidence should be outcome-based, based on local outcome research, right? And this means that we have to do monitoring and evaluation throughout the processes so that we can also handle this data for evidence, policy, and practice. We have to engage all these individuals, and I forgot to put a question mark in the middle. There's so many other people that we overlook that really have no idea what AMR is about. We need to integrate, as has been said before. For example, if our universal health coverage is there, then why are we spending so much, for example, on second-line treatment? Then it means something is not happening down there. And once again, as we've already said in this forum, we need to rethink of our diagnostics. We need to, for example, get multi-host response biomarker point-of-care test kits, which are affordable, have a quick turnaround time, and are easy to use with or without skilled capacity. One Health approach is key. I shall not belabor on that because we've already heard from the previous speakers. In conclusion, therefore, political will and formulation of a strong narrative needs to come from here. It's the only way we will have sustainable AMR implementation efforts through our National Action Plans 2.0. Urgent need for context-specific implementation that is guided by our surveillance that you guys are bringing to us. Promote effective multisectoral strategies, and we ensure that the strengthening of our health systems, and by health systems I don't just mean human health systems. We need, of course, available digestible data so that we can communicate well to our politicians, including the financial ones. Prioritization is key. One size does not fit all. Kenya cannot work like Gabon or Malawi. Everyone needs to see where they can really capture the quick wins. And of course, then we need to invest more in research for homegrown solutions to address AMR as we go through our new gaps. That is from the last bullet, rather. As we at Africa, even as we advocate now for our One Health approach, I think we can all agree that the 6-step guidance that has been provided by WHO for sustainable AMR map implementation actually will help us to be able to forge forward a sustainable AMR agenda. So I'll leave you with this food for thought from Sylvia Masebo, Honorable Minister of Health, Zambia. She really challenged us last year. If the community members do not understand the language we use when addressing this mouthful antimicrobial resistance, we have done absolutely nothing. There is need to have user-friendly AMR communication, even as we gather our data in species form, in medical form, in all sorts of form. With that, I thank you.
Thank you, Tracy, for that comprehensive presentation. So, not in African country are challenging, but we need to find a way to make it sustainable. And I know that she said that we are very ambitious in when drafting our national action plan, but we need to take on that challenge and work, try to find a way to make it work, not be afraid of the challenges. So, now we are going to give the floor to Evelyn. It's going to be a virtual presentation. She's is going to speak on the IMR priorities, CSA.
So good morning once again, and I just want to extend my gratitude to SLM and Africa CDC for the invitation to participate in this this meeting today. I also want to thank the government of Kenya for hosting the meeting, and I recognize the presence of the delegates from different countries. I just want to pick up my conversation from what Tracy has talked about in her last presentation regarding the progress that has been made in the implementation of national action plans over the last year. I thought it was interesting that she noted that the national action plans were overly ambitious, and yet when you look at the systems that are in country, you realize that we had a lot to do as countries, even before I go into my presentation. So at country level, you're wondering, are we going to fix the system? Are we going to address the NAP intervention? So we find that as countries in the low and middle income countries, you're caught in between a rock and a hard place. This overly ambitious plan actually has very critical issues that need to be addressed. Then you have a health system or an overall system within country that needs to actually support the implementation of these actions. And as I realized, and as I listened to the progress that has been made over the last 5 years, even with just this one partnership under the Fleming Fund, it just comes down to one thing. The more we are in this game, the better the results at the end of the day. There's so much that needs to be done by each of us, whether we are at country level, at an individual level, at an organizational level, at a regional level, a continental level, and eventually global level. It'd be interesting in this AMR space, and I am looking forward to really good results, because so far we've come a long way and we've achieved so much within the 5 years, even with the limited resources that each of our countries had. So if I just go briefly through who EXA is, maybe for some of us who probably don't understand who the East Central and Southern Africa Health Community is. This is a regional intergovernmental health organization whose mandate is fostering and promoting regional cooperation, especially in health among the member states. And as you can see the map that I've projected here, the countries that are in blue are the member states, which are 9 of them. And the countries that are in orange are not part of our member states, but EXA still has work that goes on in some of these countries from time to time, depending on the kind of work that is going on. So we have governing body, and I thought it was important for us to bring this here, because as I listened to the different speakers before me, I noted, and I know because I've been part of the implementation process, the importance of advocacy, the importance of convincing leadership that keeps changing every so often in terms of investing in the implementation of national action plans. And I know that the first version of the national action plans for many countries probably did not have direct investment from their own local governments, but that doesn't stop us from continuing to raise our voices and advocate for the investment into implementing the national action plans. And as I listened to the Fleming Fund Phase 2, and I listened to SLM going forward, I see the need and the very strong need for countries to use the data that has actually been generated over the last 5 years to raise the visibility and also advocate for more funding, not just for AMR, but the entire system within countries, because we realize if we strengthen the systems, then the implementation of our interventions is actually going to be much easier. So we have the Health Ministers Conference and an advisory committee that gives us a direction and oversees the operation of the health community. And then we also have the privilege of hosting the director generals from the different ministries of health as part of our highest technical committee. So when you have technical issues, it's easy to escalate them through the directors joint consultative committee to the advisory committee, which actually hosts the principal secretaries. These are the people who determine where money goes into the different ministries, and especially for health. And then we have the Health Ministers Conference. Our scope of work cuts across different areas, and that's why I think partnership is so critical in advancing this agenda for us. When it comes to advocacy, health policy analysis, harmonizing policies and guidelines across the region is one of the areas of work that we actually work in. Building capacity for human resources, and we have what we call the colleges without walls that are hosted in EXA. We have a college of surgeons, a college of nurses, a college of anesthetists, and these are some of those core groups of professionals that we intend to target even with our interventions in antimicrobial resistance. And of course, the place of research, back to health system strengthening. I don't think we can run away from this if we are to see sustained gains and sustained implementation of action. We have to go back to strengthening our systems. And of course, working in infectious diseases and non-communicable diseases, and of course, supporting and strengthening monitoring and evaluation of health policies in our country. So going into the AMR work that EXA has been involved in, this is the early investments in building laboratory capacity that started with a few countries, about 4 countries, that's like 10 years ago, under the East African Public Health Lab Network. And for the countries that benefited from this project, they had a physical upgrade of their laboratories. And we know a lot of our laboratories, in terms of the infrastructural investment, there's been very little that goes on into building new buildings for laboratories. And a good example is just going into an existing laboratory and asking for the microbiology bench. More often than not, you'll find it in a corner of the building. So the EFHLN went ahead and actually built the laboratories and had and introduced quality management systems, provided training and mentoring, and the early phases of strengthening microbiology capacity for these labs had started as early as 2016, 2015. And the 4 countries that actually benefited from this project had their early AMR surveillance sites designated from these labs whose capacity has been built. So I'm saying this because I think it's important as we work as partners in building different projects within countries, the importance of being able to build upon what another implementing partner has probably built on and has not been able to take it to another level, maybe because of funding limitations. So this country is actually able to jumpstart their surveillance programs and also go on to develop their national action plans quite early during their response. So the current project that is supporting antimicrobial resistance in 5 countries within the EXA region is called the Strengthening Pandemic Preparedness Project. And I say this because as we respond to the AMR agenda, we need to find all ways of raising the issue on antimicrobial resistance in any possible forum. So as people and countries have developed pandemic response plans, how many plans address antimicrobial resistance as a core area that is important in supporting effective pandemic response? So as part of our efforts in strengthening the pandemic preparedness in the region, of course, this came up because of the COVID pandemic that we are all hopefully coming out of. We went in and looked at some of the components that were provided for support, like strengthening surveillance, for example. And we knew surveillance is not going to be complete in the laboratory without a microbiology component. And we advocated for the inclusion of antimicrobial resistance, infection prevention and control, and also antimicrobial stewardship as part of the aspects that will actually strengthen overall surveillance systems in these project countries. So as we prepare for health emergencies, and probably a lot of funding is going that direction, I just want to speak to countries that are working in pandemic preparedness, that this is actually an opportunity that we can plug into, because we saw how much antibiotics were actually misused during the pandemic response. And we also saw a decline in the utilization of our microbiology laboratories because a lot of effort was actually focusing on detection of the COVID virus. So we can find ways of leveraging and building into existing projects and those that are actually coming up. So you can see how we got to weave in the AMR component into pandemic preparedness, and you can see under building capacity for lab-based disease surveillance, opening up the minds of colleagues who are in disease surveillance to understand that AMR is a critical component of this work. And that's how we were able to get in antimicrobial surveillance and stewardship as part of the response efforts. So we're also able to layer this on other ongoing projects that are focusing on TB. So the conversation now is how can we bring on the TB community into the AMR conversation? Because a lot of investment has gone into TB labs. A lot of investment has gone into building capacity for case management for tuberculosis. They have very strong sample referral systems. How can we work together with these already established systems so that we are able to add value to the projects already going on in country? And number two, optimize the resources that are available in a country. And taking my connection got a bit unstable. Great connection. So I was saying one other thing that we have learned is that countries are different. There are different levels of implementing their national action plan, so their priorities will also differ. So based on their priorities, then we've come in to support them both with funding and providing technical assistance to help them to implement their identified areas of work. So if I go to the specific interventions or priorities for EXA1, we have embarked on strengthening multi-sectoral governance and coordination mechanisms within countries, because we realize this is one of the weakest points. When you talk One Health, is everyone on board? And it's not just having this on paper, but actually being able to support the operationalization of the MRCCs, their technical working groups, and just providing the guidance that is required. Number two, strengthening surveillance, antimicrobial resistance surveillance, that's building lab capacity in the countries that we work with, supporting them to develop their national AMR surveillance strategic plans or operational plans or any guidelines that they would require. And then we also realized over the last 5 years, as we have built capacity for laboratories, utilization of the existing capacity has actually been low. And we thought that it was actually important to strengthen antimicrobial stewardship programs deliberately, because these are the direct teams that actually utilize this information. And if this information makes sense for the population, I think we can begin to achieve some level of sustainability, and also ensure that whatever investment is being made into countries doesn't just go to waste. And the final area of work that we are currently building is a regional knowledge exchange platform. As we have interacted with different countries, we appreciate the rich resource that exists in all our countries. A lot has changed over the last 5 years, and there's so much to learn from each other. So we are currently putting together a regional One Health technical working group that will be able to provide a knowledge exchange platform for the countries that we are serving, and also those that are beyond our member states. So we developed this first regional guidance document to implement antimicrobial stewardship programs about 5 years ago. And it's been very useful in terms of supporting countries just to customize or contextualize antimicrobial stewardship programs. So this is going to be reviewed in the latter part of the year. And I know we've been in discussions with Wande regarding the best way and the best approach we can have for the region to get good guidance, guided by the lessons that we have learned over the last couple of years. I thought I would share this with us today, just to begin to think about what we are doing in terms of investing in lab systems. And on the other hand, very little investment going into building antimicrobial stewardship programs. So this is a tool that is that was developed by the WHO to monitor the readiness of healthcare facilities to establish antimicrobial stewardship programs. And you can see some of these areas that we've highlighted in orange. If we don't act on them, like leadership and commitment, accountability and responsibility, implementation of AMS actions, education and training, monitoring and surveillance. And yet, in some of these countries, a lot of work in terms of building lab capacity has already gone in. But when you look at the stewardship component, you find that it is very weak. And the stewardship is supposed to drive the lab utilization and the use of the data that's coming out of the laboratory. And we thought that for us, this is a very key area for intervention, because in the next 5 years, if the stewardship programs don't get the kind of attention that they deserve, then there will be a balance or a mismatch in terms of the way we are using our data. So we find this as a useful aspect when we go into support surveillance or stewardship. First, there's one aspect that scored very well in most of the countries, and that's the presence of Medicines and Therapeutics Committee. So this brought us to that place where we asked ourselves, so what existing mechanisms are there in countries that you can actually ride on to further advance your agenda? So when you go into a country and find the Medicines and Therapeutics Committees are well established, are you able to build into those a strong AMS program? Because probably the chances of success will actually be higher working within an existing system. So we are still working again within the animal health sector, trying to build capacity, but we realize that there are gaps in terms of even assessing the use of antimicrobial agents in animal health in a structured way. So I think that's another area that needs to be addressed. So these are just some products of work that has been done over the last 4 months in some of the countries under the pandemic preparedness project. Like Malawi, we supported the finalization of their national surveillance guideline, which is very good from an integrated perspective, looking at both use, consumption, and surveillance in human and animal health. For Zambia, just supporting them to develop their national antimicrobial stewardship guidelines, and Rwanda the same. And sometimes we wonder what with the development of national documents. And I think for the purposes of standardization and making it easier for even scale up, when the National Coordination Committee has all these things in one place, it becomes very easy to even mobilize resources and implement work in a manner that can be tracked and monitored, and you can be able to evaluate your outcomes over a period of time. So these are just photos with some of our country teams, and I really value the cooperation and the partnership that we have with this country so far. So much to learn, so much passion, so much dedication to their work, even in the absence of resources. But there's such willingness to make a difference where they are. So I really applaud all the countries that are represented here, working with very minimal resources in difficult situations, but still determined to make a difference. So in terms of strengthening health systems and innovations, EXA, like I said, we have what we call the College Without Walls, and we now have a revamped digital academy where we are going to upload a lot of the training materials and modules that we are developing so that we can enhance access to capacity building for countries across the region. So far, we started with our event-based surveillance because a lot of our work was also picked on pandemic preparedness. We have an IPC module that is uploaded, and we'll be working again on some lab management courses and also working on MR surveillance and MS module. So this is open for everyone to use, and we are actually co-developing this training materials with countries so that it is relevant for all our member states. So going forward, I think like we have seen, a lot of our countries have developed their strategies and their plans. We are committed to supporting the acceleration of NAP implementation, one, by contextualizing priorities. I know the Global Action Plan was a blueprint, but now when countries go back to review their NAPs, I know I have had a lot of countries ask whether are we the ones who really put this activity here. Probably at that point, we didn't have a lot of information, but now we know better. So we can contextualize our priorities more. And of course, more important, incorporate the lessons that we've learned. We harmonize and integrate our actions, because as we move from country to country, there are those things that can be harmonized and those things that are context specific. If we can leverage on that, I think it should really be good. And of course, the place of national guidance and advocacy for dedicated resources, I think is important through our leadership and our governing body and our governing mechanisms we will continue to advocate for dedicated resources for the implementation of action plans. And finally, the place of data sharing and use of this data beyond the facility, beyond a region, beyond a country, at the continental level, I think is going to be critical. If our voices are going to be louder and stronger, then we must be able to analyze our data and package this data in a way that it can speak to different target audiences at any particular point. And I realized even as countries developed their national action plan, we missed out on critical support functions like data management or the IT capacity or communication functions, for example. So now we have data from our labs, which is too technical. We don't have capacity as the AMRCC to break it down further to in a manner that can be appreciated by that journalist who's interested in health and environment. So we need to build capacities for our AMRCCs on data and communication if you're going to expect a change in the next level of implementation. This is my final slide. And I put it here because the work ahead of us is a lot. We have covered good ground, but not yet at 20%. So the only way that we are going to succeed going forward as teams that are coming in for this meeting today and in other forums, we need to strengthen our partnerships for greater impact. So if there's any partner that's interested in coming into this conversation, I think we welcome all the partners and we work towards the greater goal for the people at all times. Thank you very much for your attention, and I'm looking forward to the conversation. Over.
And the good news is that so that some of them are already on the plan for the next funding round. So we will move straight to the second session. So I will call the chair of the next session, Professor Kamara, and Dr. Kazambara to chair the next session. Sorry if I pronounce your name.
How this will come about and where are we right now and how did we do this? From there we'll have Gita from One Health Trust will come around, and then we'll have our colleague from Equivia. Thank you so much.
Thank you very much, Watipaso, for that introduction, and good morning, colleagues. It's a pleasure indeed to see a lot of familiar faces that we were in the trenches as we were launching the MAP project together and implementing this project. So I'm going to take you through the 3-year journey that we had implementing the mapping antimicrobial resistance and antimicrobial use partnership. So this is going to be a co-presentation that's highlighted by Watipaso, where I'll take you through the introduction and the laboratory networks. Then my colleagues, Gita, will take us through the AMR component, and Deepak will wrap it up with the antimicrobial consumption bit. Okay, so this is what I was talking about. So what were the objectives as part of the introduction to this discussion? We sought to collect data from laboratories as well as pharmacies. Where the data was in paper format, we then sought to digitize that data so that we can be able to analyze it. Interestingly for MAP, it was focusing mainly on the human health sector. So as you are going to go through the results, etc., you will realize we have that bias as in terms of reference, we're limiting us to the human health sector. So we sought to establish that baseline for the period 2016 to 2019. So in terms of our outputs, we have 3 main buckets that we then decided to focus on. The first one was looking at the AMR surveillance readiness of the different laboratory networks in the different countries. The second bucket, which Gita will then take a deeper dive, was looking at establishing that prevalence, the trends as well as the drivers for AMR in these 14 countries where we're working on. Further on, we also then sought to establish the antimicrobial consumption rates as well as some trends and lessons learned in terms of what has been happening in these countries for those 3 years. So this work, we could not do it alone as SLM, so we had to partner with colleagues who have expertise in different areas. So we got funding through the Fleming Fund, the regional grants. So this was an ASLM-led consortium where ASLM was responsible for coordinating all the activities in this consortium. And we had our strategic partners, Africa CDC, EXA, WOW, who then brought in that convening power that they have on the continent to be able to bring all these 14 countries together and say, this is the way that we want to do. They also brought in that strategic direction that we needed as we implemented MAP. Our technical partners, One Health Trust, where Gita comes from, they then brought that expertise in terms of AMR analysis, and IQVIA brought in the expertise in terms of MC analysis. As I indicated in the objective, that we sought then to digitize the data in these countries, we then definitely needed a technology partner. So we partnered with IMSTED, who developed the tools that we were using for the data collection in this project. So we worked in the 14 countries, as highlighted on that map. We had countries in West Africa, we had countries in Central Africa, 2 of them, Cameroon and Gabon. We had countries in East Africa, Kenya, Uganda, Tanzania, and then we also had 4 countries in Southern Africa. As we shared in September of 2022, we managed to share some of the results that we got from this work that we were doing in 3 years. And I think the take home was this policy brief that we shared with most of you, and you are also going to get this during this workshop, which showed us that we have a crisis within a crisis. A lot of incomplete data on the continent. So those are some of the gaps that we want the new labs and interventions that are coming up to also address. So taking a deeper dive into the surveillance networks that we have, what we observed is that the bacteriology laboratories are scarcely represented within the laboratory networks. Of the 14 countries where we collected data, we inventoried 50,000 laboratories across those 14 countries. And sadly, only 1.3% performed bacteriology testing during that period. That's a very worrisome state for all of us. Of those laboratories that we then surveyed, only 26% used electronic LIS of those 371. Most of them, they were doing very few tests. 60% of those laboratories performed less than 1,000 tests per year. Per year. So that's like 3 or so tests per day. That's quite low. In terms of accreditation and the quality that is coming from these labs, only 23% of them had ISO 15189 accreditation, showing that we really need to start working on improving quality. My colleague Beatrice is going to speak on the interventions that we are also implementing in terms of improving the quality of laboratory testing. Less than 25% of these laboratories used automated methods. So it's food for thought for all of us. We went on to look at these laboratories to say where are they located. Because of the limitations in the funding, we only focused on 16 laboratories in each country. So when we looked at the 16 laboratories in each of these countries, we realized that 261 million people were deprived of bacteriology testing in these 14 countries. And that's quite worrisome for us. When we modeled that to say by 2035, we realized that 500 million people will be deprived of bacteriology testing. And we believe the brains that are in this room are going to help us intervene so that we can make bacteriology testing accessible to more people. We also did some work looking at the national action plans. I'm glad Yet spoke to this and indicated that most of the countries were very ambitious. And from what you can see from this graph, it basically shows the number of interventions that were in each of these NAMs. Some had as high as 65, and some of them as low as 12, thereabout. But what we wanted to focus on in all that ambition as ASLM is how many of those interventions are laboratory specific. As you can see, most of the labs, they had less than 10 interventions focusing on laboratory. So we need to start thinking, how do we increase the number, how do we increase the coverage and the capacity of laboratories across the continent? It starts with these national action plans. So as we are revising the national action plans, as we are working on these national action plans, let's take a deliberate focus to say we need to increase the laboratory interventions in these NAPs. So there is indeed a gap between what is in policy and the actual needs. And this is what the MAP project sought to bring out. So with that, I'm going to invite my colleague Gita to take us through the next set of results that we had on AMI. Gita.
Thanks, everyone, for this wonderful presentation. I think we've been going over these in the last few months multiple times. We will be having a lot of time, so I will not go into too much of detail, but of course I'll be going quickly over the findings we got from the AMR analysis aspect. So my name is Gitanjali Kapoor from the One Health Trust, and I'm proud to be part of the MAP consortium under Dr. Pascal Antoine's guidance and with my colleague Deepa. So as you can see on this slide, what we are trying to show is how many cultures we got for analysis. And this came from across 14 countries, and most of you are from these countries. And the labs, we had about 206 labs from where we got these results. So you can see that number N, it's about 819584. Let's say close to 1 million. That's a big number. So we had about 1 million cultures from these 206 labs from across 14 countries. And out of all these, not everything was in a position to be analyzed, because we were basically keen to look at the AMR rates. That means we wanted only those cultures which were positive and which had the AST results. So this was coming from about 23%, that means about 187,000 samples. Rest of them were either negative cultures or invalid cultures, that means having inadequate information, or they could be positive cultures but there were no associated AST results. That happens even in other countries. So deep diving into this interesting green segment which you see of about 187,000, let's try to see what was the composition of that, further composition. So looking into the specimen, we had maximum number of culture positives coming from urine, the purulent samples, blood. These were the top three cultures which were positive. And also looking into which were the kinds of pathogens that we got from these samples. We had Staphylococcus species, Escherichia, and Klebsiella. So basically the enterobacterials and the gram-positives were the most common. All of you have the country reports. Every country was different, so of course I'm sure all of you would have seen your reports, and this can always be discussed later. The main objective of MAP, one of the main objectives was to look into the AMR rates, to quantify, to let's say the prevalence of AMR in the countries. And the definition is something which I think all of us know here by now. It's basically the proportion of non-susceptible isolates in the country. And we also gave a confidence interval because there was a lot of source variation. The pathogens of interest were basically the WHO bacterial priority pathogens. So we know there are about 15 of them. And the results mostly came from 5 of them. For rest of them, the results were not available. What? Can somebody help me here?
Can somebody help move the slides?
Okay. Should I repeat the earlier slides or we can just continue? I think. Yes. Over this, we had about 1 million cultures from across 206 labs from 14 countries. And then out of these 1 million, around 819,000, we had the positive cultures with AST results from 23%. That's about 187,805 cultures. Now, looking into what kind of pathogens we isolated from these positive cultures with AST results and what kinds of specimens were there. So, urine, purulent samples and blood, they were the most common specimens. And staph species, Escherichia species and Klebsiella were the most common pathogens isolated from these positive cultures which had AST results. Now, the next step was, of course, to look into the AMR rates. And the definition of AMR rates is something which all of us know. It's the proportion of non-susceptible isolates, and that's what we looked for. The bacteria which were of interest were basically the WHO bacterial priority pathogens, and there are 15 of them. So when we analyzed the results, we were able to get it for 5 of them, and in my next few slides, I'm going to show you the rates for those 5 pathogens. The first one is carbapenem-resistant Pseudomonas aeruginosa, or the CRAP, and the CRPA. Now, the percent of AMR resistance was about 25 to 40% across 8 countries. So from 14 countries that we were looking into, we got results which could be analyzed from just 8 countries. And this is depicted here. This was retrospective data coming from the year 2016, 17, and 18. Now we know that carbapenem-resistant Pseudomonas is a critical pathogen. Very critical, it's fatal. It causes infections in hospitalized patients, those who are in the ICU with devices, and many a times even for patients who are immunocompromised or transplant patients. So of course there are implications of this. What do you do when you get such a high resistance? It means that we need to, and again, as I mentioned, this is only mentioned in the country reports, interventions, what's the next thing that should be done at country level, the source control, removing the device, seeing to it the patient is not hospitalized for too long. All these efforts can help to bring down the resistance in the long run. The other bacteria antibiotic combination for which we got resistance, which is alarming, was the carbapenem-resistant Enterobacteriales. It was less than 25% in most countries, so which is okay, but still it's like not something which was too less. So again, in the country reports, we have mentioned what should be done in the long run to mitigate this kind of resistance. Now, as I mentioned, we did not get data from all the countries. We used to basically be getting, for depending on the pathogen of interest, like for Pseudomonas we got from 8, but for Enterobacteriales we got from most. We also saw a resistance which was very high. That means more than 50% from most of the countries for the 3rd generation cephalosporin resistant Enterobacteriales. So these are also known as the ESBL positive. Again, cause of concern because these basically happen in patients which are hospitalized or are there in the hospital for a long term. They are on device, they could be immunocompromised. So basically similar kind of the patient profile. Unfortunately, we could not really, stratify the patients because we did not have much information coming on their clinical profile. So that was a variable of interest. Only from very few countries we could get that data, and again, that has been explained in the country reports. The fourth pathogen antibiotic combination for which we got resistance results was MRSA. This was more than 40%, and we got this information from across most of the countries. This is a high, given by the WHO as a high priority pathogen because it is known to cause infections in the skin, subacute, and even many a times in the invasive regions, endocarditis, bone infections, etc. And the fifth pathogen for which we got high resistance was a fluoroquinolone-resistant Salmonella species, about 25% plus across 4 to 5 countries. Now, I would of course love to deep dive into each of these. I'm not sure whether we have that time, but in the meeting we had in September, again in Nairobi, we went into what could be done to mitigate these kinds of resistance. So basically it all comes to reducing the risk factors, seeing to it the patient is not hospitalized for too long, removing the device, decreasing the usage of antibiotics, stewardships, and source control, hand hygiene, infection prevention measures have to be stepped up. Case of, for example, Salmonella, we need to also restrict the use of fluoroquinolones, just not in human population, but also in the animal husbandry aspect. And typhoid vaccination, screening, food handlers, and food and waterborne safety has to be also looked into. So this is a nutshell about what kind of results we got. Moving on to the last slide is about the drug resistance index, which has again been described. It's basically an index. It's something similar to the financial index which we have in stock markets. So what does the DRI basically indicate? It's one indicator which sums up the resistance across all the pathogens, all the antibiotics. It has a very simple methodology which has been published by the founder of our organization, Professor Ramanan Lakshminarayan. And this is an aggregate rate of resistance and usage. It is on a scale of 0 to 100. So if the DRI for a country is 0, it basically means that there is not much resistance in that country. But if it's 100 or close to 100, so as you move up the speedometer, it comes to 100, it means it is high. Now what we saw in our analysis was that most countries had about 60%. And what this means is that the antibiotic resistance is high, or indirectly we can say the antibiotic effectiveness was decreasing. So this also calls for action at a policy level. We need to see how can you regulate the usage and the sales of antibiotics. When I say it's more than 60%, of course, it would be very interesting if we can have a yardstick. So we are showing on this slide 3 countries, USA, Argentina, and India, as yardsticks for comparison. So for USA, it's about 18%, which is good. For Argentina and India, it's again about 60%. So basically, I think what we can say is that in the low middle income countries, there is a need for regulation for monitoring antibiotic sales and usage. So this was my last slide, and I'll now invite Mr. Deepak Batra for the next steps.
Thanks, Rita. Thanks, Edwin, for setting that up. So I will talk about, so I'm Deepak Batra, part of IQVIA. We work in the area of pharmaceuticals, medicines, with regards to data, technology, and all the areas. But without getting into it, so I think what I will cover is what we found on the antimicrobial consumption side during the MAP project, during the years we spent. So first of all, where did we get the data from? So our data came from different levels of the, I would say, the healthcare supply chain or pharmaceutical supply chain, right from the national level data sets that we acquired from the government, from the national medical supply chain bodies, also from the private sector, from the importers and distributors and manufacturers of the antibiotics and the pharmaceuticals in the country. And then we also went to community level pharmacies, hospital pharmacies, both private and not-for-profit and public pharmacies. And that's where we collected our data from. Now, just to highlight, both these data have very different kind of value. While the national level, distributor level is a lot more consolidated, so it's relatively easier to collect. But then it does not give us the kind of granularity that we need to study antimicrobial utilization and actual use of with the patients. That comes from facility level. But as we know, at the pharmacy level, that's a very, very fragmented market or a sector, and it's very difficult to collect that data unless there is a strong pharmacy management information systems already in place. But we did go to many of those facilities, and we collected that data just to show the value of both these data sets. I'll probably not spend too much time on the next slide, which is more to just show that slides. So yeah, this slide is just to show that we made sure that whatever we are analyzing, because not any two antibiotics are the same, and even under specific molecules there could be multiple dosages, strengths. So whatever analysis you will see, it has been standardized using a WHO-defined values of dosage methodology. In terms of now, this is very interesting. I think while this chart, if you see, will not be very different in the sense that most of the countries will have your broad-based, broad-spectrum antibiotics representing majority of their consumption. But what we saw in Africa in the case of these 14 countries was that only 4 molecules dominated that and almost contribute up to 2/3 of the consumption. Now, this is slightly different from what we will see, but we have analyzed and seen in other countries as well outside Africa, which kind of a hypothesis can be drawn from it is that that some of the other antibiotics, which are probably narrow spectrum, etc., are either not available or are not part of the clinical guidelines or are not part of the basically usage of prescribing behavior, which is leading to excessive, so-called excessive, or at least to say that use of these 4 molecules in higher quantities. Now, even once again, to kind of go back to it and see that is this hypothesis even valid, we did see that in Africa, 60% is the benchmark that WHO has for excess level of antibiotics usages. Now, in fact, in Africa, we saw in 14 countries, almost 80% is being of the antibiotics which are being used is excess. But that's not always to say that's a good thing, because that could also mean that actually there is a issue with regards to availability and access towards the watch and reserve category. That probably those medicines or those antibiotics are just not available, and that's leading to maybe usage of excess level of antibiotics even when where watch or reserve categories must be used. So we once again did deeper into this, saw that is that once again hypothesis true, and we actually saw that that was the case, that almost in 7 out of in 7 cases we could see that even the WHO prescribed some of the watch level antibiotics as part of essential medicine list, and we saw that in many countries those medicines were not in the national level essential medicine list, right? So which in itself would mean that the prescribing of those drugs would be limited or not happening in the healthcare facilities. So that's where we also saw that some of it is also policy driven. If policies could shape up the use of relevant watch and reserve level of antibiotics, then probably we will start seeing some of that usage in the actual market or actual prescribing behaviors as well. So this kind of also validated, although as I was saying, this is all at a national level data, and actually the patient or a facility level data is kind of missing when it comes to utilization of antibiotics, because that's when you can actually say with much more confidence that this is a rational use or this is an irrational use. This is based on high level, country level numbers of what should be the overall picture come like. So as I was saying, national level EMA, the essential medicines lists have room for improvement across categories. We also saw that a lot of FDCs, antibiotic FDCs were being prescribed and were being recommended or being consumed in these countries. Now, once again, not to say that all antibiotic FDCs are bad, but we also know that there are a lot of ones which are not registered and which are not even recommended by WHO list, which we saw a lot in the countries being consumed, which once again is a major driver of antimicrobial resistance. When fixed drug combinations of antibiotics which are used, which have not been in a way tested or which do not have the right kind of pharmacovigilance available, we know that that would once again lead to antimicrobial resistance. So, and we found that actually in 7 out of 14 countries that was happening, where we saw almost 4 to 5% of the consumption of antibiotics was for fixed drug combinations which are not approved. So I think these were some of the signs we saw. It's a slightly different conversation. I think I was very glad to see when Luna presented that antimicrobial consumption, utilization and private sector engagement is a major part of MAP to a Fleming Fund 2's focus, but we also saw that a lot of these consumption was actually happening in the private sector. The public sector, while the availability remains a major issue, but some of these fixed drug combinations which are not approved, etc., majority of this is private sector, and private sector, regulating the private sector, making sure that data from there is available will go a long way in ensuring there is minimized irrational use of antibiotics. So yeah, I think that was my last slide, but I will invite once again Edwin to walk us through the next steps and closing of the session.
Great, thanks Gita and Deepak. Message, this was the first attempt to collect data across Africa, and the message that we have for you today is there's a severe scarcity of bacterial ticks, is highlighted by Deepak. So where do we go from there, now that we have all the countries? We are proposing 4 key steps. The first one is to increase the volume and need to think seriously, how do we move from that 1% to 50% of laboratories performing bacteriology testing across the tier levels. We need to think around how do we promote AST at those lower levels. Could the essential diagnostic list help? I think so. That can be our starting point. As countries, let's come up with those essential diagnostic lists. Thirdly, digitization. We need to adopt some technology, LIS, the use of WUNET. I think we've done that for these 14 countries. We have case studies where we have seen a lot of improvement. WUNET is publicly available. That is a tool that we can quickly jump on. There are open source LIS systems. We can also utilize that. So that is around increasing the volume, the quality, relevance, and representativeness of data. We also need to start thinking, how do we develop clear measures of success and KPIs for AMR control? I think Gita did a fantastic job taking us through the DRI. Should this be something that we consider in our NAPs? We are targeting a DRI less than 25%. Essential medicines list. We need to update these and enforce these essential medicines lists so that we can reduce the use of those uncategorized antibiotics, as well as improve access to those reserve category antibiotics. Then lastly, we need then to adapt surveillance protocols that speak to the reality that is on the ground in our countries. We need to start thinking about the sentinel sites. How do we ensure that there is sufficient population coverage to support the routine surveillance that you're already doing? We need to start thinking about community settings. How do we then roll out protocols to perform surveillance in community settings? We also need to think about refining those AMR disease estimates for Africa. I think Wande spoke strongly to that. And lastly, pathogen genomic use cases for AMR control is something that I know Fleming Fund is already supporting through the SEC Africa project. So as I close, we need to take home this. We need to consolidate the country ownership. This is a discussion that we've always had, and we believe once countries have ownership to all these processes, we'll get very far. We need to build that capacity within the countries. So as we are thinking around the phase 2 of the map, these are some of the key elements we want to consider. How do we consolidate country ownership? We want the country teams, the MRCs, to be the ones who are championing that data collection and analysis in country. So we need to strengthen that capacity, the roles, responsibilities of the networks, and ensure that the private laboratories, the private pharmacies, as highlighted for the work that we did, contribute to AMR surveillance. And lastly, we need then to bridge the knowledge gap and skill gap, and my colleague Anafi is going to speak to that, what we are doing with the QUAS project to close that gap, and to ensure that we come up with an African knowledge hub that helps us to mitigate AMR. So with that, I want to thank you. We could not have done this without all these partners, so I thank you, colleagues.
Hi everybody. Let me just introduce myself. I'm Senegalese Michael Barris from Dakar University, and I'm representative of IRSF, member of the QUAS Consortium. So I will call Anafi. The agenda have been slightly modified. We'll start with Anafi, and after the lunch break, we'll go to the PQA program. So Anafi, we'll give an overview about what have been done so far regarding the QUAS training program given by IRSF.
So, good afternoon, right? My name is Anafi. I have several names. Here in Kenya, they call me Wayaki. So, but I'm commonly known as Anafi. I'm faced with an impossible situation here. It's a situation where I am standing between you and your lunchtime. At the same time, I need to present this presentation with quite a number of slides. But I realized you have been listening to slides in the morning. Sometimes they call it death by. So, talking about impossible situations, this morning I just bumped into one stone. Should I tell you the story? Yes. The mic is not very heavy? Yes. All right. So, by coincidence, the previous presenters are from India. And it's a story told about a small village in India. So, I hope Gita and Deepak can relate to the story. So there's a story of a family which had an unfortunate situation, and they got into a very huge debt, right? So it was so huge that one of the richest persons in the village came and said, okay, you guys, I'm going to give you an option. But unfortunately, this rich guy had an eye for this small farmer's beautiful daughter. And he made a proposition. He says, I can write off your debt if you allow me to marry your daughter. Right? But I'm going to give you, we're going to do a kind of a rafa or something like that. So what I'm going to do is I'll take, so they were in the farm, I'll take 2 pebbles, right? One black and one white. and I'm going to put them inside a money pouch like this. Right? So, if the daughter picks the black pebble, she's going to marry me. If she picks the white pebble, she's not going to marry me, and I'll write off the debt. Right? So they were horrified by this proposition, but they didn't have much choice. So what then happened was the farmer went into the pebble-strewn pathway and picked 2 pebbles quickly, but he picked 2 black pebbles, put them inside the pouch. So there were already 2 black pebbles. No white. No white. And the eye-sharp small girl noticed that this guy had already cheated. And now he was calling her upon to pick one of those. Can you imagine what an impossible situation this is? What would you have done if you were the small girl? So she had several options. She could decide to refuse to participate in this, but you know the result. The father would go to jail. She could decide to go ahead and simply pick the pebble. And you know what will happen? She would marry this. So, now this impossible situation, she's thinking, how can I do this? So without thinking, she decided, no, I'm going to pick the pebble. So she quickly went in, picked the pebble very fast without thinking. Then she fumbled and threw it onto the ground and mixed with other pebbles. She said, oh, clumsy me. How could I do this? But anyway, it's not a problem. Since we know that there were 2 pebbles inside here. So we check the one that remains. And then we know that I picked this one. So she had actually saved the fact. They checked, they found the black pebble. And it means she had picked the white pebble. Yes, sir. So, yeah, it's an impossible situation, but every impossible situation has a solution. So I'm hoping that I'll be able to solve the problem of doing so many slides in 10 minutes. But again, at the same time, AMR is also almost an impossible situation that we have. Right? But every situation will have a solution. We know it's not going away. Edwin and team presented a very difficult situation that we have in terms of AMR. But we are trying to do something about it. Okay, I hope that was a good icebreaker going into the... Okay, so let's talk about AMR. Right, so my topic, as you've seen, is really about the keywords, which is affectionately known as the qualifying workforce for AMR surveillance in Africa and Asia. And we are saying, I think we are moving towards the right direction in trying to solve the sort of impossible situation that we have. This is running in 17 countries, 14 of which are in this continent, and 3, namely Bangladesh, Cambodia, and Laos, are in Asia. And we are grateful to the Fleming Fund for the generous funding that has made this possible. What are we aiming to do? The keywords is really concentrating on those gaps that have been mentioned earlier on. It's all about strengthening resources, human resources in terms of their capacity for AMR surveillance through provision of microbiology and epidemiology training across the One Health. I will not repeat much in terms of these gaps. I think they have already been alluded to, but this is the reason why so many millions of pounds are being put in this these efforts, we are really saying there is shortage in terms of both the numbers and the skills responsible for doing those key tasks when it comes to AMR surveillance. If only maybe 2% of the labs are doing AST, you can imagine the challenge. Are they doing it in a quality assured manner? Again, that's another question. Beyond that, the data that is produced, do we have the capacity to interpret it? Do we have the capacity to design relevant protocols to be able to monitor such? Sometimes we realize that even at higher levels, these norms, these competencies are not always clearly defined. So, another impossible situation, so they say. But then we set out to roll out those courses under the two tracks, epidemiology and microbiology, and we envisaged two kind of levels where we would create a cadre that is able to perform field and laboratory tasks to identify and track AMR, and we could call that a skilled level. And then those that would go beyond that, to be able to design and manage systems for MR surveillance would actually be going beyond the initial. But all of this is really trying to find a mechanism of ensuring that those key important functions for surveillance under the One Health approach are actually achieved. So our curriculum, I would have gone through trying to detail what each of those is, but because I don't want to stand between you at lunchtime, I'll just mention that we do have two initial core modules that ensure that people have a common understanding with regards to AMR. And then the two tracks then divide, where the microbiology folks will continue to do lessons and practical sessions around testing for many of these pathogens, which we focus initially on those class paralytic pathogens. They also go on and do how to maintain the equipment, service it, and make sure that they avoid interruption of testing. Again, quality assured testing is also important. Yet the other folks from the epidemiology side, they really go into basics of data management and sampling. And as my colleague from REACT had mentioned, sometimes it's important that all this information is actually distilled into something that is easy to understand for various stakeholders. It could be clinicians, it could be veterinarians, it could be the general public. So a communication module was seen to be very important in how people can actually develop findings of what we are finding from the surveillance into something that can be usable. It could be policy briefs, it could be simple messaging for the public. We also have advanced techniques in the microbiology side, where we're actually looking at things that like whole genome sequencing, multi-TOF, somewhere there, and then these people have advanced so much that they end up having supervisory roles and skills, so we also included that. The epidemiology side also takes advantage of the data that has been presented here just now from MAP to see how they can really create visualizations and analysis based on the MAP data and important tools like the resistance maps that they also spoke about. Yeah, again, because we realize that we are facing an impossible situation, we tried to say, how can we do it differently? We just didn't want to do the usual come to a workshop, train, get your certificate, and go. We thought maybe it's time to try and find something that would be useful for the organization, but also for the individual themselves. So we try to see if we can have a problem sort of solving approach and link it to something that
would actually increase value of what they are getting through the SLM Academy and ensuring that the training is of high quality, and also provide an opportunity to credentialize that skill that comes through. So as a result, the qualification that we are offering comes, okay, yeah, I think it's already complaining. So it comes with a qualification and also a registration through the SLM Academy. We also know that, like I said, slides are yeah, the slides are all right. So yeah, I've already spoken to this. So we are saying, although training is a very popular intervention, we think it can be effective if it works towards clear staff norms, if it is deliberately built so that there is more country ownership, and it should comply with non-educational standards, as well as it is capable of demonstrating that somebody has competently gained the skills that are able to demonstrate that what they have. So this is what we set out to do in our framework. We called for selection of individuals. There was a selection criteria that we got there. I think you will tell us lessons learned. Did we get it right there or did we not? But these individuals were selected based on their need at country level. Based on their need at country level and their role in AMR surveillance. They will go through those modules which come as online and face-to-face modules. Upon completion of a module, they get a certificate of completion, and they go through this. At the end of it all, when they have completed this and satisfied the requirements, they get a certificate of overall completion, which comes with 30 CPD points from the Wits Health University. They don't stop there. Those who complete a set of modules that is predetermined, they qualify to write a professional exam that tests their skills and knowledge for AMR surveillance. And upon passing, they are inducted in a professional registry which is kept at the SLM Academy. And on the third day of this workshop, you will get to also witness some of those that have successfully managed to do this. And we are saying we need these individuals to keep, to prove that they are keeping this knowledge that they have. And when we register this credential, we are saying it is a means of demonstrating the knowledge and skill to competently perform those identified tasks. And this registry is kind of providing evidence that there is some level of confidence that this person is capable of performing these tasks, and it also acknowledges that the individual is committed to maintaining that competence. Otherwise, they lose that registration. So, just a quick one on the professional exam. I'm sure many of you have heard about it. It's a 2-hour exam, 110 multiple choice questions that are more on the application side of things, and each individual writes this exam in 2 hours, exactly 2 hours, not less, not more. It's online, but if you lose the internet, it also stops, and then it also picks up when you regain your internet. So we also have somebody signing a non-disclosure agreement that comes at the beginning of the test. After all this, there is also a mentorship phase. This is giving up. It really wants to go for lunch. But what we are saying is we have these individuals that have qualified, but they continue to need mentorship, they continue to face challenges in their everyday work, and they have people who are dedicated to work with them, support them, and move forward. So quickly, yeah, impossible situations. it's off again. All right, so I was about to talk about the main, some of the achievements that we have to date. As you have seen, we have that qualification framework that is based on competence, and we have conducted a landscape of what is there in terms of training for AMR, for microbiologists and for epidemiologists as well. I'll speak to that a little bit more, and I would like to also mention that should you forget about any other achievements, maybe if you just remember this slide, that would be good as well. So we have 200 cadres that have already professionally qualified, master trainers that have been also trained. That will be key as we move to the next phase. And something happened during the COVID-19 pandemic that resulted in us, by chance and maybe not by design, there was an empowerment of over 79 African and Asian subject matter experts who became very instrumental in delivering this course. So just to quickly mention some highlights of the landscape that we did, we realized that when it comes to regulation of professionals and the professions in general, the human health sector seems to be more structured and more regulated compared to the other sectors. And when it comes to the professions themselves, the microbiologists kind of have a more recognizable recognition and regulation that is more formal than epidemiologists. Maybe by design, many people can become epidemiologists coming from various initial routes. So that's possibly where we are. So we feel this information is going to be important as we move on to say how can we sustainably move on. How many did we train? The initial design was going to be a regionalized approach and targeted 80 people. But when the COVID-19 pandemic came, it also asked us, it was an impossible situation. And then we tried to do like the little girl and found a solution. So in the end, we ended up having 2.5 times more. So we have 255 professionals distributed as follows, 121 in microbiology, and then if you want to distribute them by sector, realize it's animal health, 81, human health, and then there is also a very small percentage from the food and environmental sector. Another element that came also again out of an impossible situation was the creation of a cadre that we called, it was a very difficult cadre to name. It was a trainer of trainers. So we ended up calling it TOTOT, right? So this were 12 cadres, but unfortunately, I'm sorry to say, one of them is late, she left us, so now they are 11. But they were trained to go and deliver training for master trainers who will be capable of training other people, right? So yeah, this happened, coincidentally this happened in this venue sometime last year. So those products went ahead and then trained those 58 master trainers across 5 regional trainings, and we are looking forward to see how these will actually be very instrumental as we move to the next phase. An interesting fact is there are so many stakeholders that we could touch. a lot of facilities. I will not go into the numbers, but you can see that we touched the different ministries, tertiary institutions, private sector, and moving forward. But when we speak, it looks like it was all rosy. Certainly not. There were quite a number of issues. I said the effect of the COVID-19 pandemic, you can all imagine. I will not go through most of these. I don't know, you also see that there was a skewed number of human health, and the exams tended to be skewed towards human health. And these are some of the concerns that came through. And of course, we had some people dropping out, but we are saying lessons learned. We probably need to revise the curriculum as we move on to cater for all the sectors and refine some of this. So quickly, where do we go from here? In order to go from here, we would rely on the feedback that you give us. This is not exhaustive, but we are just asking some questions to guide us. Many of the countries do not have staffing norms, or if they are there, they are not updated. So do we really know the real numbers? Certainly, some of the numbers that you have, there will be 12 people. My colleagues from Nigeria would say, how can you train 12 people from Nigeria? It's just, you can't even say a drop in an ocean, right? But how can we sustainably do this and create that critical mass? Yeah. How do we make sure that this qualification becomes relevant and useful? How do we make sure that it's recognized? Did we really adhere to the One Health approach? Somebody might argue, right? We had a few people from the food and environmental, but maybe we need to make a deliberate effort to make sure that they are increased. Did we leverage on complementary activities? We heard a lot about all activities that are happening in the countries. EXA gave a lot of reaction. How can we do this? I think Patrick mentioned that earlier on. How can we leverage what is in the country to make sure that we do it right? Again, an exam, of course, we don't expect everyone to pass 100%, but an impossible situation might require everyone to pass. Yeah. So let's think, those that did not pass, is it because they were not the right people? Is it because of the quality of teaching? Or is it because we're getting it wrong somewhere? So these are the things that we are hoping in the group discussions will come out, that will come next. But then, as we are talking about next phase, our goal remains the same. Let's go for that impossible situation. Right? And how do we think so far we can do that? We certainly want to increase, talking about the Nigerian example, can we find ways of making sure that these programs are established and then are actually uptaken? And then, obviously, we want to continue improving personal competencies and involve various sectors. Of course, from the regional level, we target those higher levels. Maybe we are targeting the national and sentinel sites. We really need to consolidate the framework and make sure that it's recognized and adopted across the continent. And my colleague Wande and myself will probably come on day 3 to say some of the suggestions that we have and hear more. I think there was an example of a bacteriology lab in a corner somewhere that was mentioned earlier on. And I would say, do we really know what are the national requirements or even continental requirements for bacteriology workforce across the continent? So, colleagues, I don't know whether I managed to do the impossible situation. Of course, it was going on and off. But at this moment, I allow you to look forward to interacting with you. Let me hand over back to the chair.
Thank you so much. Thank you so much to our presenters. You've really done justice to the work, but we will not take questions. When we come back, it's when we'll start the questions on Kwas, but also on MAM. Right now, let me invite you for lunch. We will return at 2:12. Ayatollah is looking at me very closely, but that's how it is. We need to keep to time so that we don't repeat what happened in Addis. We took a very long time. This time around, we want to stick to our time schedule. So we will go right now for lunch, and when we return, we will have 15 minutes discussion questions, and then after that, we'll invite Beatrice to take us through the EQA Africa platform. Thank you so much. Bon appetit. In Malawi, we say, Mugaje Mwino. Yes.
We won't take up too much of your time, and then we can move straight to the discussion. So our job here this afternoon is to present to you what we've been doing under EQA Africa. Excuse me. Okay. So the presentation won't be done by myself alone. My colleagues Dennis and Stephen will also join me to discuss different aspects of the program. So let me start off the presentation by just giving you an overview of EQA Africa and what we're doing. So EQA Africa is the external quality assessment grant for Africa. So it's one of the 3 Fleming Fund regional grants which are running in Africa, well, more than that, but which are managed under ASLM. And our job primarily is to ensure the quality of data that is being generated through ID and AST. That is essentially what we're doing. And the importance of that is that data that informs, right, our diagnostics and care, informs our surveillance, it informs how we use antibiotics. And so although we're coming back to quality, quality is the foundation of everything, unfortunately, so we keep coming back to it. Yeah. Hello, technical team, please. Could you? Ellie? Yeah. So what was our strategy for EQA Africa? Well, when we started with EQA Africa and we were looking at how do we strengthen quality, specifically, if you look at the name of the grant, it's called the External Quality Assessment for Grant for Africans. So the focus was on us expanding the uptake, the coverage, and the availability of EQA for AMR on the continent. But in looking at what our strategies and approach were going to be, and how we were going to implement, we recognized that just the provision of EQA alone was not going to be able to solve the problem. We also had to look at other aspects of laboratory processes in order to address the issue of the availability and coverage of EQA. And so our strategy was in 3 steps, and I'll just look at the high-level ones, and as we go through the presentation, you'll see how the rest fit. So the first was to ensure coverage of EQA for AMR under One Health by looking at what existing capacity do we already have on the continent and strengthening that. 2, increase capacity for us to establish these programs. There are lots of labs, even within these programs, which are participating in EQA, but most of this EQA is coming externally, and sometimes it's not as cost effective as something that is within the continent. And then also at country level as well, build the capacity so that, especially when you need EQA at the lower tiers of the lab, you can establish that EQA yourselves. And then lastly, improve performance of participants. Now, when you think about an EQA program, you don't necessarily think of an EQA provider as being in the role of intervening in the lab to improve performance. But we were looking at it from the perspective of EQA alone doesn't solve the problem. You need QMS. You need other interventions to make EQA effective. And so with that said, with those 3 strategies, we're going to look at what we did under strategy 1. And to help me to do that is my colleague, Mr. Dennis Imwiti from AMREF. And this strategy 1 is going to look at the establishment of the now regional EQA program for AMR. Dennis?
Good afternoon, everyone. My name is Dennis Mweti from AMREF Health Africa. I coordinate EQA Africa activities for the Eastern African region. I will take you through the next set of slides. So, through support from the Fleming Fund, through ASLM, we did establish an African-owned proficiency testing program, and 3 organizations were involved in setting this up. We had the Pasture Institute Dakar, that is handling the West African region. We have NICD handling the Southern African region. We have AMREF Health Africa that is handling the Eastern African region. So the coverage of PT participation covers the 14 Fleming Fund countries for now, because we do intend hopefully to expand beyond those countries. And our PT program has a One Health approach, whereby we involved animal health, human health, environmental and food laboratories within the region. So currently, we have 150 participating laboratories from the 14 countries. We have 30, of those 150, 37 are AMR national reference laboratories, and we do have 113 Sentinel sites. Further to break that down, we have 115 human health laboratories and 32 animal health laboratories and 3 environmental/food safety laboratories. As at now, we have successfully distributed 1 pilot cycle and 3 full EQA cycles. This has been completed to date across the 3 regional providers. So just to go into a bit on how we did this. So there was training that was done as part of capacity building. That was in EQA program establishment, and this training was done for all the 3 providers. NICD were very instrumental in facilitating these particular trainings. There was also training that was done in ISO 17043, which is the ISO standard for laboratory proficiency testing providers, because it is envisioned that all the 3 providers will eventually get their bacteriology component accredited to ISO 17043. There was also training, again held at NICD, on PT panel production, specifically on the bacteriology panels. There was staffing support, again offered through support from ASLM to get on board microbiologists, laboratory technicians, and also IT specialists to assist with data analysis. There was infrastructural support, which covered the procurement, installation, commissioning, and training on use of equipment, support to procure reagents, supplies and consumables, packaging materials for the PT materials, and also procurement of assistance in obtaining the isolates that are utilized in the PT program. There was also quite a bit of support that came in through the establishment of informatics system, that is the program design and the operational plans, and this was done through by the technical committee. There's also an informatics system which has been instrumental in running the program and making it more efficient, and this is still continuously being developed. So just to go slightly into how the program operates. So we are guided by ISO 17043, WHO guidance, and other international best practices. We also built on the existing provider experience. NICD had been doing bacteriology and other PT for quite some time, the same for AMREF, so we also did build on this existing capacity. Oh, all right, sorry. So basically, the technical, we have a technical working group that consists of membership, of course, from the providers and also members from One Health sectors to help in, to guide the design of the scheme. Then we do have the EQA providers and the informatics system that is at the core of the operation. So we begin with the scheme design, that is basically coming up with the isolates that will be utilized, setting up the questionnaires, and also the scoring criteria. Then we go into panel production and distribution, which is is now currently being done at the different sites. So each PT provider does prepare their own PT panels. Then once these are distributed, the participants submit their results using through the informatics system. These results are evaluated and graded, and individual performance reports and summary reports are then issued to the participants. After that, and this is very important in helping the continuous quality improvement of bacteriology testing, we do participant post-cycle workshops. So this is one of our unique value propositions, whereby after every cycle, each PT provider calls a meeting or a workshop for all the participants. They go through, we normally go through the summary reports. We get feedback from the participants and we interact with them, engaging mostly towards how will they now use the PT performance to improve the processes at their laboratories. Yes. Oh, okay. So after that, internally, as the PT providers, we do have a cycle review meeting, which is also part of our own continuous improvement, to sort of dissect, what challenges and how we can improve moving into the next cycle. So that's basically how the process works. So just to share just a brief snapshot of statistics, again, we do have commentary reports for all the cycles that are available, and there will be a more comprehensive detailed report, but this is just to give a snapshot of some of the data. So we do have, across all the 4 cycles that have been distributed, we do have an average 88% response rate. That is 132 out of the 150 participants on average do respond. The ones that are unable to respond, we try to dissect and find the reasons or what the challenges could be. 40% of those said it was reagent stockout. 35% said it was delay in delivery of PT materials, which goes down to customs and other logistics for PT material shipment. About 50% of participants or respondents achieved satisfactory performance in the proficiency testing cycles. Satisfactory performance is taken as equal to or greater than 80% across all the 4 cycles. So again, just to go into the post-cycle workshop, it is provider specific, as I have mentioned, brings participants together in one forum, reviews summary reports, gives guidance on corrective action, and we also take that opportunity to receive feedback from the participants. There is also the ASLM AMR community of practice. That is a knowledge exchange and networking platform. Currently, there are over 320 registered participants. There is bi-monthly echo sessions, and these are for offering technical assistance and guidance on various AMR-related issues. Finally, like I said, the informatics system is a key component of our program, and it is a free, open source, and customizable system that is self-hosted. And my colleague Stephen from ASLM will go more into those details. I thank you very much for your attention. Do enjoy the rest of the session.
Hello, Stephen, are you there?
Hello. Yes,
yes,
I'm
please
here.
go ahead.
Yeah, can you
Tell
hear
me when you want me to change the slides.
Okay. Yes. So Dennis has already given us a brief overview of the system. So let's go. So the EQA informatics system is, as Dennis said, is the system we use in managing our cycles. When we started the project, we decided to.
Stephen, could you hold on a second, please? The volume is a bit low. My apologies.
Okay.
Okay, speak and let's see.
Hello. Is it better now?
Yes, please go ahead. Much better.
Okay. Okay. So we decided to go with an open source system than a commercial system because we wanted to have a system where we could manage, we could have access to the source code, and we could make changes. We also didn't want to start from scratch because of the time constraint. And so we decided to evaluate some existing systems from existing providers and look at what we could get and continue from there. We evaluated about 4 systems. The CDC EPT used to manage HIV viral load. We also evaluated the AMREF system. We evaluated the NICD and then the DTU systems. So eventually we decided to go with the EPT system, which was developed by CDC. Now this is an open source system, and we enhanced the system to be able to manage our AM.
Hello, Stephen. Okay, so while Stephen, we're still getting Stephen back, I'll just go ahead with the presentation in the interest of time. So as Stephen said, we evaluated the 4 systems and used, decided on or agreed on using the CDC EPT system. Now the CDC EPT system, for those of you that know it, is mainly just designed for VL and EID. It's a very basic informatics system. So there was a lot of work that we needed to do to upgrade it to be able to have a bacteriology module and to be able to manage a PT program for AMR. So everything you see here includes features, and it's more that we've developed on the system, including being able to have multiple EQA providers running on the system at the same time, but also having them isolated for their programs, having their brandings and logos. You can have clinical histories and pre-reporting questions. It's translated into French at the moment, and we're thinking of also doing translations into Portuguese. You can look at qualitative data as well as quantitative data. So all of these are included in the system, and I don't want to go into each one, but yeah, there was a lot of work that was done to upgrade it. So when the system, as Dennis said, is very integral to the operation of the PT program, essentially participants register through the system, cycle notifications are sent out through the system, they report in the system, and we also send out their individual reports and the summary reports all in the system. So there's a lot that it can do. This is just an example of what a report, an individual performance report looks like, and this is anonymized, so it's not for any particular lab. This is anonymized. So this is what the report looks like. So you have all the different details, and again, I won't go into, I hope that in your pen drives you will have the presentation so you can look at it in your own time. And then these are also aspects of the system itself when you go into EPT that looks like, if you are a participant and you go into the system, what do you see? If you're a provider and you go into the system, what do you see? So there are different elements here that are used for the reporting. Bacteriology, unlike other PT programs, is very complex in terms of how you're reporting, and is very much based on the panel you're also using. And so again, there was a lot that needed to be done to be able to customize this system for this program. Again, here we're looking at a dashboard in the system that helps us to look at certain parameters which we're monitoring, so that we make sure that we're in line or online or in terms of what is going on. So new PT surveys, ready to ship PT surveys, and survey events as well. So you can go into the system and look at all of these. Again, these are just different sections of the system, and again, please, it looks at, prior to this looks at the shipment setup, the language setup, publication management, because we do keep all our summary reports on the system, so you can access them and read for each PT cycle. And basically that's it, and I'm sorry that I've gone through it very quickly, but when you have the presentation, you can take time to look at it. And also, we may be able to share a link where you can just have a dummy to run through the system. Moving forward, we're still customizing and upgrading the system. And I think that's important to note. I think we see that this system, beyond just AMR, it's a bacteriology module that has been created and can be used for any bacteriology program. And similarly, we want to see how we advance this moving forward so that the system can manage any PT program. So just to end on the PT, now that the program has been established and is running, we also need to start thinking about sustainability. I think one of the issues we have in most of our programs is sustainability, especially when it's externally funded. And so from this program, from the very beginning, we started business planning with the EQA providers. And through that, we have business plans which are being finalized, which is provider specific. And we also have a costing tool that can help them to cost EQA programs. And this tool is not just for the providers. It can be made available to anybody, regionally or nationally, who is thinking about establishing a PT program and wants to know what is it going to entail and how much is it going to cost. So for the EQA program, what does phase 2 look like? Well, we won't go into too much detail because we're going to discuss that tomorrow. But the discussion is still ongoing, right? So this is why we have this consultative meeting. But areas of focus is looking at continuing to expand the program within the 14 countries and perhaps beyond, further upgrading and customizing the system, and then further capacity building for the EQA providers is very important. So for strategy 1, which was the EQA program, that is what we have done to date. And we're very proud of the program because, as we said, everything was done by us on the continent. And then the next strategy was to strengthen regional and national capacity for the establishment of EQA programs. And here what we have focused on is building knowledge and skill in what, if you are a laboratory professional in your country or you are in the Directorate of Lab and you are asked to establish an EQA program, what is the knowledge and skill that you need to know? So we've developed what we call the EQA training and qualification framework and exam. So it's a training framework and qualification exam, which provides EQA providers and participants, and I'll come to talk about what key elements of EQA provision and participation, and it's through targeted training and a competency assessment for the exam. So for the providers, our job in the training framework is to train them on the establishment, operation, and management of EQA programs. So what do the standards require? How to produce panels, everything to know with the logistics and operations of EQA program establishment, results, evaluation and grading, provision of support. So everything that goes into the management of an EQA program is captured in this training framework, and similarly in the qualification exam. For the participants, we're very specific. I think when we started this whole program, one of the things that was very clear was when we looked at why was there not uptake of EQA, apart from the fact of cost, right, and having money to buy EQA programs, one of the things we realized was the appreciation of what EQA does for the lab and how it helps us to analyze, assess, and improve our systems. Without that understanding, it's very difficult for you to justify the cost of EQA when you're already in a resource-limited setting, right, where you don't have enough resources for your day-to-day operations. So part of this curriculum is also looking to train labs and to say, what value does EQA have when you are participating in EQA? Apart from the fact that you know that you're mandated to do it, you get a sample, you test it, and you have to send a result. There is a value to you. Do you understand and know what it is? Also, do you understand how EQA programs operate? Because through our own experience, some of the errors we see is from lack of understanding of how programs operate, how to perform cause analysis and corrective action for your performance as well. So the structure of the program is just shown here. So you have the training, then you have the exam, and then you have a practical exam as well. So we're not leaving that out. We recognize that theoretical alone is not going to enable you to be able to produce panels, right? So you need a practical. Then you have the qualification, which is then conferred, but that qualification doesn't last forever. You are going to have to be requalified after a specified time period. Okay, so the exam will be run through the ASLM Academy. So what does this qualification mean? Well, if a person comes and goes through the training and takes the exam, you will be qualified to say that you have the relevant knowledge to support the establishment and management of EQA programs. But again, you saw in the cycle that we mentioned the practical. We are not forgetting the practical, and we're recognizing practical skill is also important. But what we do know is the practical is happening now without the knowledge. And that is another gap that we found. A lot of countries are providing PT, doing EQA programs without the requisite knowledge and skill of what it means and how to do it correctly. So hopefully by doing this, we are bridging a gap both ways. Moving on to our third and last strategy, which was to improve uptake and performance of participants. Here we're talking about EQA essentially. So establishment and strengthening of EQA across the priority countries. And we were really targeting national reference labs and sentinel sites. So we had a roadmap which included, assessment, mentorship, technical assistance, and in some aspects, some infrastructure capacity building. But most of our work was around the TA, training, mentorship, and looking and assessing your system and helping you to address the gaps. We are supporting 57 labs to date, and you can see the number of labs per countries. We have 47 NRLs and 10 Sentinel sites. Of those, 40 are human health, 13 animal health, and then we have 4 food safety and environmental labs. So out of these to date, what we've been able to achieve. So we've been able to accredit 10 labs to date. And out of that, we have 1 environment and food safety lab, 5 human health, and 4 animal health labs. And the accreditation is on both sides. So there's some who we attained accreditation for the first time, some who we supported to retain the accreditation, because that's very important. A lot of labs get accredited and can't maintain the accreditation for various reasons. And then also expansion of scope. A lot of labs will say they're accredited, but when you go and check the accreditation, it doesn't include bacteriology, because bacteriology is very tricky. And so that expansion of scope to cover bacteriology was also important, and we focus. So every single lab accredited here includes bacteriology in their scope. Finally, what about those labs? We were working with 57 who we haven't accredited. Well, we've still been working with them to improve their systems. And you can see here from baseline to exit assessment. Let me qualify this by saying that not all the assessments have been completed. They're still ongoing. But for the ones that we have completed, which are approximately, I think about over 20, you can see that there's been a significant improvement in their assessment scores. And from baseline up until exit, we're looking at an average of 32% increase in their scores, which is great. We're very happy with that. And so we hope to work with them further to see them improve some more. We do recognize that not all labs will receive accreditation, and that shouldn't be our target. Our target should be quality improvement. And so even if we are able to achieve this, we're happy. Okay. Then lastly, there has to be an aspect of capacity building. So over the course of the last 2.5 years, we have trained over 300 laboratory personnel on all the trainings you see here. So you can see the topics and the number of trainings that we've been able to have. Now you can see that the numbers are large. And that is largely thanks to COVID, because we couldn't, although we wanted face-to-face meetings, we couldn't travel. So we adapted all of these to an e-learning format, and we were able to do it quite effectively, but that also allowed us to have a greater number of participants in participating in each of these trainings. And thank you to all our partners who supported us with these trainings, especially CLSI. Last and not least is about sustainability and scalability. This is a long-running conversation and problem. So we're doing QMS, so you get labs accredited. So the Fleming Fund and Luna go away. How do we sustain it? And we are saying that we cannot continue to sustain it by relying on external funding. We need to look in-house. We need to have now transfer ownership, development and ownership of these programs to the country. So have country-owned and led program development and implementation with clearly defined standards of quality through the lab-tiered network. And for that, we developed with our partners DATAS the guidance for establishing a national laboratory framework, which we're very proud to say is CDC endorsed now, Africa CDC endorsed and launched. And it's available to anybody, by the way, on the Africa CDC site. So this document guides and facilitates country-level efforts of strengthening national laboratory networks, so helping you to look at and revise either your laboratory policies and strategic plans to really incorporate quality programs into them. Because a lot of them don't. They mention quality, But they don't say, how are you going to do it? How is it going to be done through the tier? What resources are we going to allocate to it? Who is going to be responsible for oversight? It doesn't say. So we want to strengthen these. And then the strategic plans are important because that is where you allocate the resources, right? So we want to see that. So we want to see the country developing their national quality programs and implementing it. And that way we're supporting the countries, not the other way around, right? We're providing support to roll out their own plans, but not going to the country with our plans. And currently we're working actively in quite a few countries. We've been implementing this over a year to look at moving that process forward. In a lot of these countries currently we're just focusing on the policies and strategic plans, but moving forward we want to see more, provide them with more technical support to actually translate that into programs that they'll be implementing. So what's the way forward for EQA Africa? Well, that's a conversation we'll be having over the next couple of days or so. But we've already done a lot of work in analyzing our achievements, our challenges, and our many, many lessons learned. And this has helped us to refine and define the proposed activities which we'll be looking at tomorrow and helping to you or consulting with you on how we move forward with them, or whether we move forward with them, or whether we need a new approach. And the activities and outcomes from our other grants, QUAS and MAP, is also important. There's a lot that came out of QUAS that has informed what we are going to be doing next. There's a lot that ANAFI is doing that informs how we will move forward in terms of training and qualifying staff under EQA Africa. And so we always have to look for these opportunities for alignment and how we make sure that we're consolidating all our efforts to have a larger impact. And then, last but not least, is the consultation with you. Everything we're doing is for you. So you have to tell us what you want, what are your priorities, what you want us to do, and more importantly, how we can work with you to get it done more effectively. Because I say that there are lots of lessons to be learned from phase 1 on how we can do that better. So with that, I'd like to say thank you to the Fleming Fund. My slides are not changing, but I can see it here. And every one of you, the AMRCCs, the MOH, the laboratory directors, who have supported us in many various ways for us to achieve what we're presenting here today. Our technical partners, DATAS, CLSI, Caveat, we can't thank you enough. Chid is here, Melissa is not, but you can call on them anytime to provide support, and they're there to give you the knowledge and expertise. And please, I cannot end this by thanking our consortium partners, Africa CDC, Dr. Yanu, One Day, Dr. Itenu, thank you very much. NICD have been so instrumental in building the capacity of the other EQA providers. So Professor Perovic is here. Thank you so much for that. And to everybody else for their contribution. None of this could have been done alone by ASLM. Thank you.
Thank you so much, Beatrice, and the whole team which presented on this strategy. Now I will call upon Beatrice, Edwin, Anafi. Let's just come in front so that it gets easier for the reflections. As Beatrice was winding up, she said, we were doing this for you. Isn't it? We're doing it for the Africa we what? We want. So let's have the discussion. Let's ask questions, clarifications, contributions, so that tomorrow we can go to the in-depth of the way forward. Our technical team, would you assist us with mics? Yes? Oh, we have the mics. Oh, so I didn't even, imagine I didn't see. It's not an experience being a chair now and again. Eh? Yeah, so the mics, we have them. Let me have... questions on Zoom. Oh, okay. All right, but let's start the in-house. Yeah. Gita, please come in front. I'm not saying hands. By now I need to be saying some hands, someone who wants to add in a few reflections, a few questions, or even country experiences. Yes, Masha? There's a mic in front of you.
Thank you so much for the presentation. I want to reflect on the QUAS and also the Africa one. As a country, we enrolled environmental sector into this program, but when we wrote the exam, it was not really reflecting on that sector. We hope in the second phase, we are also going to include them.
The reflection? Or what I would do, I would just buy countries, because we can't keep quiet, guys. We've eaten a lot, I know, but we can't give. Let's start with Zambia. Oh, there is a question. Sorry, Zambia. Let me start that question. Yeah?
Is that given for me? Yes? Yeah. Thank you very much for a very nice deliberations and discussions around the EQA for AMR. As you know, AMR is one of the serious problems, not only for Africa, for the globe. It is threatening the future challenges of the health sector and the economy as well. So I'm very much pleased to attend this meeting. I'm Garamut Aso from Ethiopian Public Health Institute, Director for Bacteria, Parasitic and Zoonotic Disease Directorate. Then from this morning to up to now, I would see discussions, and lastly what Beatrice presenting how Ethiopian Public Health is going to be part of this EQA participation, because I wouldn't see any participation. We are sending some data to GLAS, and also we actively working on AMR. We are now currently has scaled up to 16 sentinel sites, and we have been working with CDC, and now currently we are actively working with CDC, Africa CDC, US CDC, Ohio State University, American Society for Microbiology, and extra. So others are also coming and joining to us. So we need to also part of this type of quality assurance to keep moving forward to contain antimicrobial resistance to share our part according in the play role in East Africa. Thank you very much.
Thank you so much. We'll take one more reflection before we. Yes, Tanzania.
Yeah, so thank you very much, all the presenters. I just want to give, I don't know if I can call it a question or rather just a comment. Like most of the data that we are generating, like from the different hospitals to the WHO GLAS, they are mostly generated from like national level, either from tertiary hospital or maybe from regional hospitals. And for sure, we know the majority of the patients are actually attending the primary health care facilities. That's where the majority goes. So there are two things here which I'm suggesting. We may find a way as countries which are participating in the African context, maybe each country should have like a pilot, maybe 3 or 4 facilities at low level, so that much as we generate data from national level, from tertiary hospitals, at least we have like 1 or 2 hospitals at lower level, which can actually give us a reflection of what is exactly happening on the ground. We did it, for example, in Tanzania. We had a project called SNAP OMR, and we piloted it in 3 district hospitals. And we showed that the results are totally different. For example, the resistance to 3rd-generation cephalosporin for different bacteria which are causing, let's say, UTI, bloodstream infections, and skin and soft tissue infection was less than 15% in the district hospitals. But then when you took on our surveillance data in the database that we are submitting to the national lab and subsequently to the WHO GLAS, it was ranging from 40 to 65%. So I think let's use this platform to see how best, at least we can have a pilot in our respective countries so that we can really get the data from the grassroots where the majority of our patients attend for the routine healthcare service. Otherwise, I thank you, all the presenters. It has been a very wonderful discussion. Thank you.
I think we can have some responses. We've seen some questions on QUAS, we've seen from EQA Africa, and then I think some reflections on modeling at country level. So I think.
All right. Yeah, so I think the other question might have come before I came up here, but I'm told the question was, are we planning to add additional sectors to the ones that we have? Yes, so initially we had largely animal health and human health. So I'm glad to say just about, I think a month ago, we were in Nigeria with the colleagues, and we really discussed that bit. And it was felt that if we really have to stick to the One Health approach, we certainly need to include. And we were so glad that we actually had representatives from the environmental sector also coming through there. So yes, we intend really to go beyond. And one of the intentions is, can we really look at the curriculum to see if we can also cater for all those sectors. I'd also like to point out, I think the team from Zimbabwe, initially from the word go, of course the distribution was not the same, but they really went beyond the human and animal, and they also picked the food sector as well. So I think if we are to fight AMR, we need to really make sure that I think all of these are actually catered for. And it comes to the issue of representativeness that also was being discussed. I hope I've responded.
So the two questions for EK. Number one was whether we would have more representative panels for the different sectors, which we will. I think one of the things when starting the program was to make sure we had generic panels that everybody could test, because you're starting, right? So you want to start somewhere. But moving forward and looking at the program design into phase 2 is to say, what are those priority pathogens per the sectors, and can we have more representative panels for that? And that is a discussion we've already had and is ongoing. In terms of the inclusion of EPHI in the activities, there's always scope for us to discuss how that happens, in what capacity. We know that we are providing EPHI with support through EQA Africa, and there were discussions initially about supporting you with the further development of your EQA program. I acknowledge that discussion, and we will see how maybe we can move those discussions forward. Thank you.
No, I think not. Well covered.
I think we have more questions now. Let's start with Zambia.
Yes, sorry, excuse me. I wanted to have some response about the sites at community for AMR. I think that this is acknowledged that when the country reports to GLAS, sometimes only one facility at higher level is actually contributing data. So the whole point, and I think that's the vision of Africa CDC and ASLM, we really have to reinforce the cohort and the fleet of sentinel sites, so that we have a more representative surveillance system, and that will be discussed tomorrow on how do we move forward, so that it's not only a couple of laboratories that either have the time or the capacity to send data, but we have data that are representative through the network of sentinel sites. Thank you.
Oh, thank you so much. Thank you for those presentations. My question is to Anafi on the COAS trainings. It is a very, very good program, and we started the trainings in Zambia as well. But I think this is the time of COVID where we had, I think, some dropouts. So I was just looking at the numbers that we remained with during the training. Like Nigeria said, it's like a drop in the ocean. So I'm just wondering, what's the plan? Are we going to just go with the numbers that we have? Thank you.
Yes. Another hand there? Yes. I think somewhere where there is Uganda.
Thank you so much for the very beautiful presentations and the work you've done. I have just two concerns. One is about, it's a general concern that is about the inclusion of diagnostic stewardship in improving the quality of AMR data. A case, for example, in Uganda is you find a lot of data is generated, but when you don't have the laboratory clinician interface, it is basically garbage in and garbage out, so you get a lot of data that may not be representative. The next question is on the, I'm sorry, I may not have your name, the lady who presented about the drug resistance index. I'm wondering whether, what your comment is about drug resistance index being a measure that is promoting overuse or excess use of antibiotics as opposed to what we normally recommend, that you limit the use of antibiotics in terms of estimating the index. Thank you.
Yeah. Since
yes, thank you very much. My name is called Stella. I'm from the Animal Lab in Uganda. Yeah, I think I'm audible. Yeah, I had a chat with my friend there who, is it Gilbert? So, no, her. Gita, yeah. So we've seen that actually the data which has been presented there on the different aspects of AMR, that it's mainly from the human lab. So it doesn't reflect what is in the animal sector. So probably as one of the consideration, if you could also profile how is the picture in the animal sector, maybe in the environment, looking at the One Health approach, so that we are able to see key points where we can address. Then also on the issues of, just adding on what Zambia said, we realized because of COVID, in terms of workforce development, other people could not cope up with the online platform that were put in place, so they ended up pulling out. So what considerations are we having there so that we don't miss out? But generally for me, as in from the Animal Lab, I feel actually as much as we are seeing that we've made significant strides for the animal sector, but still, to me, I feel we are lagging behind, and we need to be helped so that we come up with accreditation, and also in terms of the Animal Lab actually participating more actively, especially in EQA and quality assurance and accreditation. Thank you.
Excellent. Let's have Nigeria. There was a hand, then we'll have the responses. We'll come again. Nigeria.
Okay, thank you. I also work with the National Laboratory, Animal Health Laboratory in Nigeria. The last speaker just have talked about what I wanted to speak on. We've been talking about One Health, and just like many speakers have said here, that if we want to achieve, reducing AMR, the three sectors have to come on board and, be strengthened. And I also want to appreciate the EQA ASLM, especially for supporting my laboratory, which is undergoing accreditation. We are just a few steps to getting that accreditation. And it's very key because just like it was highlighted, if the laboratories are not strengthened, it will be very difficult to achieve, reducing antimicrobial resistance. And especially, we all are aware that the animal health laboratories in most African countries is limited, and therefore there is need for strengthening of those laboratories, because if we also know that most of these infections, move from animals or are shared by both animals and humans, and including the environment. So if they are not tracked at those levels, it will be very difficult to achieve what we want to achieve ultimately. So I want to believe that maybe the next phase, should a bit bring up the environment and the animal health sector so that they are also strengthened. Thank you.
I think it's very clear now. We can't overemphasize the need to go through the One Health approach. We know when we were starting in 2019, we couldn't start flat out, isn't it? We needed baby steps. So that's why, especially in MAP, we focused on the human health. In EQA Africa, we thought of starting up on only human health, but I think along the way, Beatrice made up, and we got in the vet labs. So we know that this is really something we can focus on. And when we leave another sector behind, we will still go back to the same what? The same issue. So I think, Luna, you're here. Your critical understanding the need. Yeah, I think this one I will not give to these guys, but let me give it.
Now, just to say that that is across all the Fleming Fund investments. So it's more advanced in human health, and animal health is lagging behind, and the food sector and then environment. That's what you saw in the strategic shifts. The first one was animal health, One Health, and environment surveillance, because we are aware that we need to focus on that and trying to make it balanced. So yeah, we are aware of that, and we are really trying, but yeah, please keep telling us and come up with all your ideas. Thank you.
I think now let's have some responses, not on One Health. Let's focus on the course. Let's focus on the DRI. Yes.
Yes, so thank you from Zambia. I didn't get the name. Oh, Chileshe, yes. Yes, indeed, certainly I think that was one of the points that we mentioned. COVID-19 came through and we had to find ways of doing that. We did what we could, but certainly I totally agree with you. Again, I think we will have a session, a dedicated session on Friday, which we have called Domesticating Cures. So initially, in our thinking and our discussions with some of you, we are thinking maybe if we find a way of bringing something closer to home, maybe we can do more. Maybe we are wrong. So let's discuss and see whether that makes sense. But I think many people agree that I think when something is brought closer to home, I think it's better manageable, and we may be able to do more numbers. What is most also important is, do we really know how much of what we need? So I think those are some of the steps that we need to think of. Do we have, maybe even before we just start training, do we even know how many we need to train? We will certainly not do them all at once, but maybe we are saying, I think somebody was talking about national level sites providing data, but we are also ignoring some of those that are at lower level. Maybe we need a certain way of saying, okay, we are designating these ones, and we are going to target the following. And then our next phase is as follows. I think if we are able to, during the planning, if we are able to sit together and be as candid as possible, to say, this is what we need, even if it's just so gigantic, but this is what we can do in 2 years, and this is what we can maybe do in 4 years, and maybe if it's like a free radical chain reaction, the things that we produce now will help produce more. But what is important, I think Wande and myself will also provide that perspective that we have from the continental level. We are trying to say, can we set a minimum expected standard of competencies and skills for people who are going to work at such levels doing these tasks? They may be, that standard may be too high for maybe a certain country, maybe because of the background of the people that we're looking at. We're saying, can we customize to see, can they get something that is below that standard to catch up? But maybe some people in Ethiopia or in Zambia, that minimum standard we have already outlined is not good enough. Maybe they are already advanced, they want to add. But at least if we agree, all of us, at a minimum, we have this one in between, we can add this left, we can add the right. But again, it's all about really determining what we need. Of course, the resources will tell. Fleming Fund only maybe may not be enough, but who else can come on board? Our professional authorities, regulatory bodies, the various sectors, whether it's the Ministry of Agriculture, Ministry of Health, Environment, how can we really work together to make sure that, maybe probably they have resources that are there, but because we are not one, yeah. So I'm looking forward. I don't want to preempt a lot of this discussion, but I'm looking forward to Friday. I think our colleagues from Nigeria will start with something. Our colleagues from Asia will also say their perspectives. And then we can see what makes sense. For certainly we know maybe what works in Ethiopia is not necessarily what works in Zambia. But what is important is to identify the best way that works in a context.
So I'll take your question on DRI, drug resistance index. I think somebody had raised that question. Yeah. So I think what you were trying to ask is, what is the implication of a high DRI? That's what I understood, right? What can we say if it's high? Is it because of what reason? Did I get that question right?
How effective is it in differentiating excess use? Because you find that excess use of antibiotics, especially a broad spectrum, could give us a low DRI, yet in reality we are advocating for low use of antibiotics.
So DRI actually is, it's one index, it's a parameter more for policymakers, because to them you cannot explain a lot of AMR in detail. It's for them basically to take an informed decision on what is missing in the country. You can't really pinpoint on what is the exact cause, because DRI is a mixture of two different parameters. One, it talks about the resistance in the country. Two, it talks about the consumption in the country. So it talks about both. And it's like an amalgamation, it's a mixture of both. It's like the inflation index. Now, at the same time, if you have a high DRI, you can think from different angles. You can maybe say that, yes, possible that the country doesn't have access to the antibiotics. So whatever you're having, you're just using that. You don't have access to the right antibiotics. Whatever is available, you're using them over and above. So it's kind of a misuse, and of course, it will bring a lot of resistance. Two, you can also consider it in the other way, that you're overusing even the right antibiotic if that is available. So from both perspectives, it does say that the effectiveness of the antibiotics is decreasing overall. So what you need is basically the policymakers or the regulations to be so strong that a proper antimicrobial stewardship is practiced, and we try to bring down the resistance. Yeah.
I think that is one discussion, Kita, we can continue to do.
Absolutely.
There's a lot of lessons which we're learning from analyzing our data from the DRI index. When you look at your data, when we receive the country reports, critically look at those reports. Look at what was consumed within 2016 to 2018. That's when you see how this was critically calculated. We were also one of the countries where we were saying, no, I think we can. Actually, we are the second, isn't it? We are 76.74. But when we saw in 2016 to 2018, from our central medical stores, Malawi only had 5 molecules which we used that period. So when we now look at, we correlated now with our AMR data, now we saw our increase in resistance, showing really that our DRI, yeah, there are things to discuss about other things, yeah, but when you would be to 0 or to 100 to say, I think there was something which was missing. Yes, we had access drug, but there were some drugs which we didn't have, and there was hugely consumption of these drugs. So I would really, really encourage countries, when we receive these reports today, let's look inside those reports. There is extremely a lot of data in there which can really inform us of what we're doing. And actually, right now, as we think about reviewing our standard treatment guidelines, reviewing our essential medicines, it's good to look at that data so that we can see what we are using in the country versus the index which we have. Let's move on. That was some serious talk, but let's move on. Let me go to, is it Sierra Leone? Yes.
Okay.
I think 10 minutes to finish this.
All right. Thank you very much, at least, for giving me the opportunity, and thank you all for the presentation. You can see these faces are not familiar faces. I can see Anafi was just from my country, Sierra Leone. But one thing I just want to emphasize here, I know we are talking about a regional grant, but also we need to reflect how the country grant can also affect the implementation of the regional grant, for example. For example, with the QAS, we expect, for example, to build on what the national grant, the country grant has worked in terms of the laboratory. And Nafi will agree that currently we have serious challenge with actually the country grant in terms of renovating and making our laboratory work. So that's a serious challenge. And so there's one aspect of the regional, for example, the QAS, for which we need to do a hands-on laboratory work. And we expect to build on the country grant, but we are not yet there. So that's one big challenge also, even though we are here discussing the regional grant, but we also need to see how the regional grant can also work in collaboration with the country grant. And at times at the country level, because we may have different grantees, we have some challenges. And then I'm sure, of course, in terms of the regional grant, we are happy to be here. And I'm sure not all the countries are on the same pace. Some of us, we have serious challenges, and we are happy that we have the opportunity to sit on the table and discuss how we move forward. And then also, one thing that I did not hear much about, I don't know whether this is the wrong forum, is about the fellowship program related to AMR. So I did not hear much about it, and then I don't know whether we are going to discuss more about it, but it's also something that we look forward to. Thank you very much.
Let me have, there's a lady here from Cameroon. Let's have Cameroon, then we'll have Eswatini. There has been a hand.
Okay, thank you very much for the opportunity. I have one question on drug resistance index as done by the presentation. It was mentioned that it's very high in African countries, and an example was made with USA where it was about 80%. So I want to know if it is possible to decrease this index, and what is the standard level, because I think it is not possible to reach 0%. And now, what are the strategies to decrease it? Because many speakers also mentioned that antimicrobial resistance is already a threat, even an emergency. But maybe I missed it. I didn't see any response framework, any document presented on how now to respond when we have some result, because we discussed about surveillance data. When we will have those results, is there a threshold to act? Is there some guidance for politicians to make decisions at what time, at what level, how to do it? So that is my question. Thank you.
Excellent. Eswat, thank you so much. Eswatini?
Mine is actually a comment. Thank you to the presenters and also to Fleming Fund. You know, the approach that you adapted, we have actually learned a lot from it. In terms of regional approach, also in terms of national approach. And I don't want to influence the selection criteria for the grantees for the second phase. But it's better the devil you know than the one that you don't know. So in such a way that we, you know, in terms of the country grant, we have worked very well also with the regional grant. But in particular, I just want to thank Edwin. He has been an outstanding in terms of coordination. At times we will shout at him. And we'll tell him we don't want to do this. And some of the things have been achieved because he has maintained that coolness and was always willing to assist. So Edwin, please keep it up. We are actually raising a young politician here who might end up.
Thank you.
Having said that, to the QAS training, I wish we can also include the pharmacy participants so that we can have that approach. And then I also want to know from other countries, I'm supposed to be the chair of the AMRCC, and I am the chair. But coordinating sectors, more than one sector, has been a challenge, but it's doable. and it's documented that once achieved, a lot can be actually achieved. So I don't know what's the experience from other countries, but I wish we can share those experiences. You know, the Fleming approach is that capacity building. Now we have the data. What are we doing with the data? Can we use the data for policy direction and for programming? So, and then lastly is the issue of the National Action Plan. I wish we can also involve our regulators so that they can also influence in terms of the trainings and also in terms of the uptake. Thank you.
Excellent. Let's Nigeria, and then we'll go to Uganda. Select one. Can you combine the answer? You've been talking a lot, everyone knows you, but let's have the new guy.
Okay, thank you very much. My name is Tochi, and I'm from Nigeria. Well, early this morning, we were told that we need to use data, digestible data, so that we can present clear communication to decision makers. I would like to share with you how one of the ways we've used the map data in Nigeria. Last year, I don't know if everybody in this room knows that the ministers of health, the ministers of the sectors were in Oman for what was called the Muscat Declaration. And from the data in Nigeria, our map data shows that the access class, we were doing below 60%. And we discussed with our ministers, at least our Minister for Health before he left, and he was committed to signing that Muscat Declaration that committed Nigeria to getting to 60% access. So I want to put it on the table that that is one of the tangible ways we have utilized the map data to inform and to prepare our Minister for Health before he went and made that commitment. And he came back, and the first thing he did was he told us, I want this to get into the NAP. I've committed for this. I've committed to this, and this must happen. So just so that you know that that is the way. And we're also currently reviewing our National Action Plan. In fact, we're just trying to finish it, and we're at the stage of situational analysis. And the MAP report is one of the documents that we are reviewing to inform action. And one of the key things that came out was the inequitable distribution of labs in the country. And that immediately linked us to the cost of blood culture bottles. And as we followed that discussion, a couple of things came out that we might be decrying the cost of blood culture bottles at this point because we found out that it's cheaper for somebody in North America, an organization or a country in North America to procure blood culture bottles than it is for somebody in Africa. So, yeah, that information came out, and therefore each time our representative at the Global Leaders Forum then goes out, we give him that information to continue to make that case for equity. And we are now trying to see how we can then drill down capacity in all dimensions to get to the secondary care levels. We're also now discussing what equity for blood culture means for us as a country. So just to put it on the table that we have started utilizing the map data in some tangible areas. For the QAS side of it, we'll be very happy to discuss on Friday how we're utilizing the how we're planning to take the QAS going forward. A lot to say, but I don't want to hold up the mic. Thank you.
Thanks. Let's wind up with you this session. We can talk on and on because they're beautiful stories, isn't it? The conversation keeps getting better every day, but we need to curtail so that we need to focus on other things.
Okay. Thank you, the presenters. My name is Jonathan Maito, and I represent the country grant in Uganda. So I have two questions. And one goes to the gentleman who presented about the map data. I don't know what your comment about the quality of data. There's a chart that you showed that showed a positivity rate of 23%, and then negative and commensals of 60%. Yeah, so I would like to hear your comment on that, because it seems to be a low positivity, and then the negative rate is also quite high, and why you had to merge the negative one with the commensals, because that's where we would really do the quality check. And then I want to emphasize a point that was brought up by my colleague earlier on. I know this is SLM and it's lab. But a lot of what happens in the lab is affected by what happens on the diagnostic side. So what strategies do we have to strengthen the laboratory clinician interface? Because it all starts with the clinicians. If we give you garbage, you will get garbage out of it, and maybe partly explains the picture that we see. My second question is on the EQA. Beatrice, I come to you. Thank you for such an extensive training program, but I wanted to hear if you have a mentorship program. One of the gaps that we realized in the sites is the review of the results of the EQA performance. So sending feedback of the results is not enough, you know? So people fail for different reasons. They may fail to interpret the question, they may fail in their processes to as they execute the panels. So there's a lot that happens, they're all reagents. But if there's a concerted effort on feedback, rather than giving back results and trying to strengthen where the weaknesses are realized. Some people have been discouraged when they get poor results. Next time you send the panels, they will not work on them, or they work on them and they don't send results. So the mentorship aspect, I think, needs to be strengthened in the ecosystem. Thank you.
Let's have the responses so that we can finish by 3:30. Straight to the point.
Yeah, quickly. So I think I would like to acknowledge the point that was mentioned by Dr. Kanu, the complementarity of the regional and country grant. Yeah, I think it's indeed something that we can improve on. We have some good examples, like where you see infrastructure. I think he gave that example. There are countries where it was easy to do the advanced modules because the infrastructure is already there, and I think that I think is important. I think we need also to better plan together, particularly when I'm looking at the point that Dr. Chileshe mentioned earlier on. When we are saying we have a sort of minimum standard that we want, and if we realize that there is need to maybe bridge a gap, maybe for the case of, say, Sierra Leone, I know the country grant WHO also runs some courses that are there. So I think it's all about identifying which bit is being done by which one. I know Luna wants to also add to that as well.
Yeah, thank you, Dr. Kanu, for that question. So I would like to ask something more about the coordination. So you were asking how this is going to be coordinated at a line and how the fellowships also fit in this. So in phase 2, as if you remember my colleague Patrick this morning, he says it's going to be this country approach now. So for phase 2, there is going to be a country investment strategy. So some of you I know have been working on this already. The rollout is going to be staggered, but all countries will have this exercise. So the Fleming Fund with your country and with the country grantees and all grantees will decide what are the expected outcomes for your country in phase 2. And at the table we'll see the country grantee, the regional grantee, the Fleming Fellows, the AMRCC and relevant country stakeholders, and decide this is what we want to see, these are our expected outcomes, and they will see, okay, this is what is being produced in phase 1, this is what is needed, who is going to do where. So this will have to be done together. That's what I also talk about, this harmony that's needed in phase 2, because we are aware that there were a lot of challenges around coordination with the different investments in most of the countries. So that's the plan, and it's going to be led, the coordination, by the country grantee.
I think we can talk on and on, but I would ask Gita to come to the team here on a side meeting to explain the DRI. It's a critical mass which it has to be explained in details. How did we calculate it? And what are the specifics? Just in a, but we need the country to engage, because I know, you know, one thing which is very nice about government, when these meetings are coming in, we have different people who are coming in now and again and again and again. So from where we are starting from with where we are right now, we have different people who have seen this information now and again. So we still need to get into our colleagues to get them understand, because this is one of the critical things. When we present every time about these results, we have booming what? Questions, which means it's really critical. People need to understand. So I don't know if you can do it within a minute.
So yeah, I can just kind of first maybe give my inputs that on the DRI, the report, the country report, I'm not sure if you've got the chance to read the DRI. We have a methodology mentioned in that, which is very clear. So if you want anybody in our team to explain you step by step, we'll be very happy to go over it. That's one. Yeah. Two, you wanted to know the yardstick, right?
No, sorry, please. Mine is just to know, with these results, what are the strategies to reduce it?
Yeah, I was coming to that.
If there is a standard level
so
that
there,
is required.
So this is something like, there is nowhere in the world that you can say AMR will come to zero. That's impossible, right? It's just that the lower, the better. Nobody can be, it's like health. You can't be in the state of optimal health 100% without any illness or disease. And AMR is basically in the environment, it's in the genes. And it's a natural selection of the bacteria to just survive. So it will remain. The only thing is, try to minimize it as much as possible with at least avoiding human interventions. So it's man which is misusing the antibiotic, and it's just increasing the level existing. So lesser, the better, and the yardsticks we can take, I would say, is for the developed countries, which is like in US. That's why we had that bar where we showed US has about 18%. So we always try to say that whatever is in the developed countries, they have better resources, everything better, even the data management, analysis, surveillance systems, much stronger because, of course, they have more resources. So let's try to aim at lesser the better. I won't say 18% for US is the best, because we know AMR is there also. So the lower you go, you can never achieve 0%. Well, that's going to be a impossible target. It has to stay. So anything less than maybe less than at least 18%, I would say it's ideal, but nowhere would you find what is ideal. 60%, of course, is really, really high.
To finalize, Beatrice, there was a question on mentorship on EQA. Can you just shed more light to our colleague from Country Grant in Uganda?
Thank you. So for the EQA, we already, as in the presentation, we have the post-cycle workshops that we use to bring the sites together. The point is, and that's why we are combining the EQA program with QMS implementation. The QMS is really where you get that training. It's not the provider's job to help to mentor the site on how to perform corrective action and because generally it's not, right? But in our program, we took the initiative to say we want to do that as well. And we do that through the post-cycle workshops. And then in the countries also, for each country working with, we have an SME. So one of the tasks of that SME is to engage with the labs, to review, help them to review the reports and to look at how to look at the causes of their poor performance, do the root cause and implement corrective actions. But essentially our job must be to make you be able to do that because we can't cover every lab in the country, right? And so through like the EQA qualification, training and qualification framework, the participant part of that training is all about doing that, building your capacity to do that. EQA training also does that. So we will continue to do that and to work closely with you to do that during the next phase so that we can build capacity in country to do that yourselves. Thank you.
So let me just share an example, Uganda, what we do in Malawi. We decided we are going to work as one, whether it is country grant or it's a regional grant, because they are the same labs, same patients. So whether you like it or not, it will be under the MRCC.
So what we do is we took off QMS from the country grant and took it to EQA Africa. So what we do is when the EQA panels are coming, we have a pool of mentors within our AMRCC. When the EQA comes, we pull them to the field to go and mentor the facilities. So the country grant has got money for review meetings, which EQA Africa doesn't have. So we call these labs each and every quarter to review what EQA Africa is providing. In so doing, we have achieved an 85% of that. So what I'm saying is, AMRCCs, you just need to be stronger. See how these can integrate. Effective coordination starts when you pull all this basket of resources together. There is nothing like a country grant separate, like a regional grant separate. Then we will not be able to achieve a desired what? Outcome. But we need to sit in on one bench and discuss side. One thing also, with the help of our Deputy Director, Mr. Betelenyo, we pull even money from World Bank QMS, from SATIP is called what? TB program, HIV program. So we pull all those resources. When we're doing a review of QMS, of EQA, it is all that basket of all the EQAs in the what? In the country. So when you have a system which is managing this and you're talking to one another, mentorship, you do not need Beatrice. You just need the SME to oversee the what? The implementation, and it works in very what? I know it's really a lot to take, but a day at a time. Stepwise, it is very, very possible. In country coordination, there are a number of countries. Who is the AMR coordinator who wants to support Eswatini? Who want to mentor Eswatini? Before I just point at you. Huh? Joseph, you've seen some challenges. I'm pointing at you because of the challenges you've gone through. Joseph will mentor you. What does it mean to have an effective coordination? Because you don't need, if the way I am as an AMR coordinator, I am not an AMR coordinator for lab. I know I've got a lab background, but when I am coordinating AMR, I am not a lab personnel. I am a coordinator of human health, of environmental, and of what? Of animal health. And I need to look across all these areas and prioritize them and govern my team. So it takes in a lot, but Joseph, you see, you have someone, you will have a discussion on how we can be able to do it. Another thing also, one day in the team there, don't just think that when we have AMR coordinators, we have it all. These AMR coordinators, they need mentorship. They need guidance. What do we do? How do I study this program so that I can effectively be able to deliver it to my team in the country so that they can be able to implement very well? You see these programs, these are 3 programs, isn't it? Nowadays in our countries, there are too many. There is ICAS, there is REACT, there is Pfizer, there are too many just now coming in. These AMR people, as AMR coordinator, need to be capacitated. I don't know when we're going to form this platform. The way you've done the laboratory directors, I know it's going on very well. But we need to capacitate the AMR coordinators. I know they do not have a number of structures in country, but we are looking for them to deliver so that these projects can be what? Can be very impactful, but also can be what? Can be achieved. So these are some of the things we need to think through as we what? As we move forward. Let us clap hands even for me and the team. It's been very beautiful, isn't it? And look at the enthusiasm within the team. It means the next 2 days it's going to be very good discussion, isn't it? So we're calling you next 2 days. Let's come in with these discussions so that we can reshape the next phase of these grants. But excellent work, guys. I will now leave it to, as we close down, leave it to Edwin. Edwin, over to you now.
Thank you very much, Watipaso, for moderating such a very exciting session. So as Gita highlighted earlier on, that we have some country reports that we are going to be sharing with the countries. So this is the time. So the SOP for receiving these reports goes like this. Each country, you are going to nominate one representative. We've spoken to some of you already. Who is going to come up front. We are going to hand over one copy of the report and a flash drive with the soft copy of the reports. And Dr. Yenu and Mr. Ndlovu, our CEO, will hand over this report to you. We'll take a few shots, then you go and sit down. When all the countries have received their reports, we'll then come back to the stage and get one big group photo with our reports. So that's how we are going to do that. So I'm going to invite Mr. Ndlovu and Dr. Yenu to come upstage. And Beatrice, my assistant, can come and help me. Oh, Irene is coming. Right. So the first report goes to Tanzania. Dr. Kayuni, before you go, can you just hold it like this so that they can get a photo? Fantastic. The next report, Uganda. The next report goes to Eswatini. Thank you, Eswatini. The next country is Cameroon. From Cameroon, we'll move on to Zimbabwe. We move on to Malawi. Oh, sorry. Next in line is Gabon.
French.
We move on to Senegal. From Senegal, we go on to Ghana. We come back to our hosts, Kenya. Next is Sierra Leone. Next is Zambia. Last but not least, Nigeria. So before Dr. Yenu and Mr. Ndlovu go and sit down, I'm going to invite all the country representatives who have received these reports to come for a group photo. I also invite Dr. Pascal, our ASLM Director for Science and New Initiatives, to also come, as well as the MAP Consortium partners who are here present, Gita, so that we can get a group photo. Yeah. Yes. Oh, I didn't see you. Fleming Fan, please. Yeah, it's okay. You can, yeah.
Which one is the official one here? we need to look for the official. Is the official done? He must pass his force.
Thank you very much, colleagues. you want one photo? Oh.
So it is not inside.
Which one?
Where did they get? Yeah.
There's nothing in there. You opened it?
We opened it, we put in the two computers.
So, okay. Yeah, your French version is coming.
Hey.
You remember we translated. Yeah, so it went for proofreading, so we couldn't print on time, but it's coming. So we're actually going to do 20 copies.
Okay, because I'm waiting for the French version to go and give it to the minister.
Yes.
And to organize that workshop.
Yes, so I think in the next 1 week or so.
I have where we can give that to the minister and explain to them.
So you'll be in French?
Yeah. So
when do you intend to do that?
we're supposed to do that after the.
Yes. Great. Thank you very much, colleagues. Great. So
don't forget people online, just acknowledge that your questions are there, we'll tackle them tomorrow.
Okay. Thank you very much, colleagues. I think in terms of the handover of the reports, this brings us to the end of that session. Our colleagues who are online, we have noted your questions, your comments that you have. We will definitely be addressing them in the next 2 days. So with that, I want to hand over to the session chair to close the session for us.
It's been a wonderful session, isn't it? And thank you so much, countries, for participating in this good work we did. We did it for us, isn't it? We did it for us, and we're so proud of this work. And we move now forward in the next 5 years or 10 years of our national action plans, get these recommendations and put them into what? Into action. We want to see the next map, Nigeria, move DRI to 36%. Is that possible? Yes, it is. They said 0% is not possible, isn't it? But 25, as USA, it's possible. But Africa, like me, 50%, it's what? It's possible. You know what it means when we move a step further? It means we are doing something. We are doing something for our people. So thank you so much. And I'm also privileged that I was a chair. We had many chairs, isn't it? But I think I took longer, isn't it? And I am so happy about it. I'm so happy that I am so happy that I've made you live and I have made you energetic to stay on your toes. Tomorrow we are starting at 8:30. And when we come in with such energy, we'll be able also to finish at 16:30 and have a lot of discussions. So I am wishing you a very good evening. Let's move around. We are in the peak of town, isn't it? We can move around in Kenya. It's still free, isn't it? Yeah, move around. No, you don't need a driver to move around here. You need an Uber. Excellent, excellent. It just means that we've had a very good day, isn't it? Yes. So let me ask Secretariat, is there anything? Let us clap for all the chairs today. We had chairs since morning and they have done excellent work. For this, the meeting is closed. We meet tomorrow morning at 8:30. Thank you.